We are live.
Good evening, everyone. A very warm welcome to you all on behalf of the All India Ophthalmological Society. And I welcome you all to yet another episode of GuruSangam. So, this is our 14th session this year. And Guru Sangam literally means a confluence of teachers. And through Guru Sangam, we invite experts in their field to lecture on a subject of their choice. Each lecture is in depth and is designed to give you not only a coverage of the theoretical aspects of the topic, but also some very valid practical pearls. So, through Guru Sangam, the objective is not only to educate, but also to elevate the standards of postgraduate teaching across the country and help our postgraduates to excel. In this episode, we'll be diving deep into the realms of retina, and we hope to fetch some very precious pearls that's going to benefit all the audience that has logged in this evening. Before we begin, I'd like to acknowledge Dr. Partha Biswas, the president of the AIOS, Dr. Santosh Honavar, the Honorary Secretary General of AIOS, and Dr. Manoj Chandramathur, the Honorary Treasurer of AIOS, for having so beautifully designed and curated all the talks in this program. We have a virtual galaxy of speakers, experts in the fields of retina to talk to you today, and I'll just give you a brief introduction to them. We have Dr. Reshma Mehta, a retina consultant from the Ashwini Medical College and Research Center, Solapur. Dr. Vijay Pratap Singh Tomar, a UVA and retina specialist from the Autonomous State Medical College, Hardoi. Dr. Sujata Padhi from the MKCG Medical College, Behrampur. Dr. Rajvinder Kaur from the Adesh Institute of Medical Sciences and Research, Bhatinda. And Dr. Dhananjay Shukla from the Ratan Jyoti Nethralaya, Gwalior. A very warm welcome to you all and really looking forward to all your talks. We also have an expert panel who would be giving their inputs and perspectives at the end of every talk. And a very warm welcome to you all. Thank you so much for sparing time to be with us this evening. We have with us Dr. Dhanshri Ratra from Shankar Nethralaya, Chennai, Dr. Mukesh Purwal from the Retina Hospital, Purwal Eye Clinic, Rajkot, Dr. Obuli Ramachandran from the Center of Sight, New Delhi, Dr. Shushma Jayana from Narayan Nethralaya, Bangalore, Dr. Tapas Padhi from the LV Prasad Eye Institute, Bhubaneswar. So welcome to you all. This is the flow of the webinar. So we'll be starting with the talk on retinopathy of prematurity, going on to white dot syndromes, retinitis pigmentosa, central retinal artery obstruction and central retinal vein obstruction, and then a talk on hypertensive retinopathy. I'm Dr. Tinku Bali. I'm a retina consultant at Sir Gangaram Hospital, Delhi, and I'll be your moderator for this session. My co-moderator would be Dr. Rolika Bansal, who is an oculo-oncology and oculoplasty specialist from the Mahatma Gandhi Medical College, Jaipur. So once again, welcome to all the speakers, the presenters, the discussants, and also a very warm welcome to the audience that is there with us this evening. So with that, I invite our first speaker to please share their presentation. And our first speaker would be Dr. Reshma Mehta, who would be speaking on retinopathy of prematurity. Over to you, Dr. Reshma. Before we begin, I'd also like to encourage the audience to please post their questions. This webinar is live on YouTube and on Facebook, so you can post your questions in the comment section. You can also post it in the chat box, and we'll take the questions up from there. So, Dr. Reshma, is Dr. Reshma there?
Yes.
Yeah, please, I'll just stop sharing and then you can share your slide. Yeah, Doctor.
Is my screen visible?
It is visible, but we can't see your presentation. Your screen is there, but you're not your presentation. Ma'am, have you opened your presentation on the desktop?
Yes.
And then I think you stop sharing and then share again.
You're not able to see it?
No.
Now?
Yes. Perfect.
Yes.
Yes,
Good
go ahead.
evening, everyone. Respected seniors, dear colleagues, and PG students. Today I will be speaking on ROP, a disease which is not only a high yield exam topic, but also one of the leading causes of preventable blindness. I repeat, it is preventable blindness because we have to act on time. ROP is a unique disease because vision loss is entirely preventable, provided we identify the baby at the right time, at the right time, at the right time, and the provided we identify the baby at the right time, at the right stage. Through this talk, I will briefly cover the pathogenesis of ROP. I will focus on the ICROP classification, edition 3, the screening guidelines, and the management, ETROP, which is most relevant for us as ophthalmologists. So to understand ROP, we must first understand the normal retinal vascularization. The normal retinal vascularization begins at the optic disc at 16 weeks of gestation and reaches the nasal retina by 32 weeks. It reaches the temporal retina by 40 weeks. Hence, if the baby is born prematurely between 32 to 40 weeks, the temporal periphery will remain avascular. This is when a baby is born prematurely, a large portion of the peripheral retina remains avascular. And this incomplete vascularization is the substrate for ROP. ROP is a disorder of incomplete retinal vascularization in the preterm infant. And hence we need to identify these babies and treat them at early stage. Coming to the pathogenesis of ROP, it is described as phase 1 and phase 2. So phase 1 is where there is hypoxia and it leads to vessel loss. It occurs at 32 weeks. And what happens is because the baby is born preterm, even the room air, there is a physiological hyperoxia. And the baby finds it as if there is more oxygen even in the normal room air. Also, the baby may develop asphyxia, the baby develop RDS, the baby maybe have to be given surfactant. And in all these conditions, what happens is the oxygen is pumped in. And when the oxygen is pumped in, there is hyperoxia. So this leads to oxidative stress and it sends a message to the brain saying that the stop oxygen. So there is a drop in the VEGF levels. When there is a drop in the VEGF levels, there is retinal vascularization which becomes obliterated and vasoconstriction happens. When there is vasoconstriction and vasoobliteration, the retina remains avascular and the peripheral retina, the vessels do not grow there. This happens in phase 1 because of hyperoxia, there is vessel loss. Now, what happens in phase 2 is there is a VEGF surge that happens a few weeks later. There is hypoxia. There are many times when there is fluctuation of oxygen levels and the baby seems that there is less oxygen to the baby, delivered to the baby. This leads to increase in the VEGF levels. When there are increase in the VEGF levels, it is increased to 137 times than the normal. And this leads to new proliferation of the new vessels at the posterior pole, leading to AROP. So if we have to give anti-VEGF drugs, we need to give them between 32 to 35, 36 weeks when there is high level of VEGF in the circulation. At 39, 40 weeks, the VEGF levels start decreasing and there is increase in the TGF beta. When there is increase in the TGF beta levels, it leads to fibrosis and crunch effect if we have given anti-VEGF drugs. Hence, we need to give the anti-VEGF drug at a proper time. This diagram shows that because of the increased metabolic room air, there is vasoproliferation because of the increased VEGF levels. So as I have already said that there are fluctuations which are harmful than the absolute oxygen. So it is not just the high oxygen, but also the fluctuations. So it has to be blended oxygen, only that will help the baby to grow better and see better. So the NICU support also should be good, and it should not be haphazard. Like sometimes they are giving oxygen, sometimes they are not giving. It should not be that way, because these fluctuations lead to more damage. And we can see it in the retina, as there are vasoobliteration, constriction, again dilatation of the vessel, and sausage-like vessels, bleeding. So this fluctuations should be avoided, and rather blended oxygen should be given. So after the pathogenesis, we come to the risk factors who will develop retinopathy of prematurity. So naturally, the babies who have been born premature, that is less than 34 weeks, are to be screened. Those babies who have low birth weight, less than 2 kilograms, should be screened. Those babies who have required oxygen support in the NICU should be screened. Those babies who have been diagnosed with sepsis, have been given blood transfusions, should be screened compulsorily. Also, there are other risk factors. These risk factors should not be missed, and all the babies in the NICU should be screened at least once to identify the disease. So, whom to screen? Babies who are less than 34 weeks, or babies who have who have their birth weight less than 2 kilograms. Even the sicker, bigger babies also should be screened with all the previous risk factors already mentioned. And using the dilating drops, we have to be very careful. We have to give standing orders to the nurse in the NICU, saying that the diluted tropicamide 0.5% with phenylephrine 2.5% should be used. Only 3 times the drop should be administered. We should monitor the heart rate and the oxygen levels. Also, the extra drops should be wiped with excess drops should be wiped from the skin, and punctal occlusion should be done so as to avoid systemic absorption. Another is we need to watch for any apnea or bradycardia and avoid feeding the baby before and after examination. Also, another thing is we should not use the 10% phenylephrine or 1% cyclopentolate. And also, we should never miss the screening. Now, when to screen is 4 weeks after birth, compulsory we should screen all the babies, or 31 weeks post-menstrual age. There is a famous crucial awareness slogan that says, "Tis din roshni ke." So it is for preventing blindness in premature babies. So it is very important to know when to screen. Coming to the ICROP classification, ICROP classification, the third edition, ICROP classification was written in 1985, then in 87, revised in 2022. It has 3 components: the zone, stage, and plus. Even if any one of these is missing, it is incomplete diagnosis. So all these 3 should be mentioned when we are mentioning the diagnosis. It is a standardized system for describing and staging the disease. The location is the zones, extent is the number of clock hours, and severity of the disease is defined as the stages. ICROP third edition also tells us about aggressive ROP, that is AROP. It also tells us about the posterior zone 2. It tells us about plus disease, and it tells us about the notch. ICROP third edition is important because it helps doctors to communicate through one language, because we will be putting it in one format, and we can track the disease progression and guide the treatment properly. So coming to the zones, zone 1 is a circle centered around the optic disc with a radius twice the distance from the disc to macula. It represents the posterior pole and is the area with maximum rapid progression of the disease. If not treated, it has a poor prognosis. Zone 2 is extends from the edge of zone 1 to the nasal retina or the nasal ora serrata, and the zone 3 is the temporal crescent. So I would like to show you a video which we have made. Just a minute. Okay. So, this was actually a model which tells this is the zone 1, then this is the zone 2 around the zone 1, and this is the temporal peripheral retinal crescent which has the zone 3. And why it is being shown this way? Because the nasal part touches the ora serrata. This is the nasal ora, and the temporal retinal periphery, the temporal ora serrata is over here. So never that we will have the disease as zone 3 on this side. This will be always zone 2. ICROP third edition has described posterior zone 2. This is 2 disc diameters around the zone 1, because the disease in zone 1 is seen progressing anteriorly, and hence this has been renamed as posterior zone 2. Coming to the stages of ROP, which describes the severity of disease in clock hours. So in stage 1, we can see the thin faint line which demarcates between the vascular and the avascular retina. In stage 2, the demarcation line has now got a width and a ridge, and a height and a width. And in stage 3, there is extraretinal neovascular proliferation. And in stage 4, A and B, stage 4A tells that there is tractional retinal detachment not involving the macula, and stage 4B is tractional retinal detachment involving the macula. Stage 5 is again divided into A, B, and C. A is stage 5A, is the funnel is open. Stage 5B is when the funnel is closed, and stage 5C when there is anterior segment changes like shallow AC and secondary cataract. So we also have another video which tells about the stages and how it is for the layman. So usually when I have to tell my patients, I would tell them that, see, this is the retina, which is very thin and silky. So, the vessels which are developing towards the retinal periphery, because the baby is born prematurely, they are not reaching the periphery. And hence you have a vascular area and an avascular area. First, initially, it was a thin line. Now you have a ridge or a wall which is been there. And this area is the avascular area behind the wall. This is how we tell our parents when we are explaining, this is the avascular area. And if we do not treat or come and screen the baby timely, then the entire retina will be detached and the baby will become blind. So ROP starts as a mild changes in the eye, and if not detected early, may lead to serious damage. So we have to tell the patient that it is very important that they come on time and get their baby screened as the date is given or mentioned in the file. ICROP 3, third edition, also defined another term called as notch, where the disease process, there is an indentation, a U or a V-shaped indentation from zone 2 to zone 1, thus telling us the severity of the disease, that the disease is increasing from zone 2 to zone 1. And it is the junction of the avascular retina to the vascular retina, and there is a short dip of the retina into from zone 2 to zone 1. So this was another term which was described in ICROP third edition, which tells about the severity of the disease. Then we have the plus disease is defined as dilated and tortuous vessels at the posterior pole. This occurs because of fluctuations in the fluctuations of oxygen levels in the neonatal care. So you can see the tortuosity and the dilatation. So this is surely because of a lot of fluctuations, lot of hypoxia, hyperoxia, and hence there is this plus disease. It applies to the posterior pole. It happens in the posterior pole. There are no vessels in the periphery. It is totally avascular. It requires urgent treatment. Earlier, there was also a term called as pre-plus or threshold disease, a rush disease, APROP, aggressive posterior retinopathy of prematurity. Now, in ICROP 3 classification, we have aggressive ROP. So this is aggressive retinopathy of prematurity, formerly called as APROP. Now it is renamed as AROP. It involves more anterior zones and larger babies. It is characterized by rapid progression with typical and it has typical changes like flat NVE, vascular loops, and a large vascular area in the periphery. This is also vision threatening and hence commonly involving zone 1 and posterior zone 2. Requires urgent treatment. All this time we have been talking about the retina and we have been looking at the retina as retinopathy of prematurity, but we should not forget to look at the anterior segment also. When we look at the anterior segment, we can find this as called as neovascularization of iris, NVI. It can be mistaken for TVL, that is tunica vasculosa lentis. And you can differentiate from TVL because this is not organized well, but TVL is more uniform. This looks more angry looking. This is because of severe ischemia, severe hypoxia, leading to more of VEGF levels, and hence there is more of neovascularization. The pupil is not dilating in spite of putting Tropic Acid Plus drops of with proper concentration. And the media is not clear, but if you give a gentle massage, it may clear and you may be able to see the retina. When you see the retina, you will not see the dilated and the tortuous vessels, but you will see obliterative retinopathy, obliterative vessels, small, thin, thread-like vessels. So it is a clear-cut ischemic pathology, severe hypoxia leading to NVI and obliterative AROP. This is another disease where anti-VEGF helps, and ICROP classification has helped us to tell that this can be treated with anti-VEGF because laser is not possible in such tiny babies who are not able to sustain the laser. And it is difficult because the pupil is also very small and not dilating. So anti-VEGF works better in such cases. So when we have to treat the baby, we have to know the ET-ROP classification, that is the early treatment retinopathy classification. Those which fall in type 1 ROP of ET-ROP, we treat them immediately. That is, any one of the following requires treatment. That is, those babies who have a disease in zone 1 with any stage 1, 2, 3 with a plus. Those who have a disease in zone 1 with stage 3 even with or without plus. And those who have a disease in stage 2 or 3, zone 2 with stage 2 or 3 with plus should be treated within 48 to 72 hours. It is very important to treat the baby in time because medico-legally also it is more uh, important. Otherwise, it becomes a medico-legal issue if the child goes blind. So we have to act well in time, coordinate in hand with the pediatrician, neonatologist, nurses, parents, and the ophthalmologist, because here the time is crucial. Type 2 ROP, we need to observe closely. These patients, they have the disease in zone 1 and the severity of the disease, that is stage 1 or 2 without plus. And those patients who have the disease in zone 2 with stage 3 without plus also should be observed. But here again, because it is a medico-legally important, we have to take a consent. We have to tell them properly that a very, very close follow-up is important and needed. If they do not come and if the child goes blind, then we are like the neonatologist or the ophthalmologist is not responsible, but the parents are responsible. Hence, medico-legally, this is important. So we have to make sure that we ask the patient to come for follow-up and see that we are not lost the patient for follow-up. This is very important. Then mild ROP, that is no treatment needed. Zone 2, the disease is in zone 2 and the severity of the disease is stage 1 or 2 without plus, or the disease is in zone 3, that is in the crescentic temporal peripheral retina. So here treatment is not needed, but you can have a good follow-up. So why ETROP is important? Because it replaces the threshold ROP. It promotes earlier treatment. It reduces retinal detachment and blindness. And it takes care of the medico-legal aspect also. So this is the same triage what we just discussed, that if the disease is in zone 1, whether it is stage 1, 2 or 3, we need to treat it. And if the disease is in zone 2, but with stage 2 and 3, again, we have to treat it. And those diseases which are in zone 3, we can follow them up. And without any plus, we can follow them up. But those diseases with plus should be treated immediately. So what is the treatment protocol? What are the modalities of treatment? We have lasers, anti-VEGF, and surgery. So coming to first as laser, lasers is the gold standard treatment. It is recommended for zone 1, any stage, zone 2, stage 2, and 3 with or without plus. So treatment for type 1 ROP remains photocoagulation of this avascular retina. So the avascular retina should be ablated, photoablated. Laser the avascular retina anterior to the ridge to reduce the ischemic stimuli causing neovascularization. So it provides permanent ablation and has excellent anatomical outcomes when performed timely. So this is good laser done. And here we have a large skip area. This we need to laser it anterior to the ridge and complete this. So that this, if we leave it as avascular, ischemic stimuli will be there. And again, there will be neovascularization. So we need to complete this laser. Coming to the next modality of treatment is the anti-VEGF therapy. Anti-VEGF therapy is given when the disease is in zone 1 or as aggressive retinopathy of prematurity. We have two drugs. We have multiple choices, but what we usually use is bevacizumab, half the adult dose, and ranibizumab. This has a high recurrence rate. So useful, anti-VEGF is useful in the posterior AROP. It is usually good for the sick and the unstable preterm babies where laser is difficult. Injections should be given in operation theaters under strict aseptic precautions. after informed consent. However, anti-VEGF is not a one-time cure. We have to have a very strict and a long-term follow-up because there is reactivation of the disease. But what are the advantages? Are it has rapid disease control, effective in posterior ROP, preserves the peripheral retina, as against, as we saw the initial laser, the child may have a peripheral field loss when the child grows. So here, better visual field potential, less myopia, and it can be combined with lasers. But we have to take care that there should be no infection. We inject it properly so as to not cause any traumatic cataracts or vitreous hemorrhage. Coming to the surgical option for treatment is when the baby has progressed to stage 4A or stage 4B, that is partial retinal detachment without involvement of macula. We can do pars plana vitrectomy. And even for stage 4B, when there is macular involvement with guarded prognosis, we can do pars plana vitrectomy, sparing the lens. But in stage 5, we need to do pars plana lensectomy, vitrectomy with scleral buckling and with silicone oil. And here the prognosis is very poor. The patient may only have vision for navigation. And all the stage 4A, B patients have guarded visual prognosis. So we have to be very careful again while posting or referring the patient and with due respect to the medical aspects. So follow-up schedule. This is very important because when screening should stop. So those patients who were in stage 1, where the disease was not very aggressive, those patients, we can follow them up to 45 weeks, see that the vascularization is complete, and we can follow them up only for refraction. Either they have refractive errors or amblyopia or squint. So we can follow them up slowly like that. But those patients whom we have injected, we need to follow them up very well, very strictly till they become big, almost as much as 65 weeks, and even later to see any reactivation of the disease. Those patients with lasers also need to be followed up to 45 to 50 weeks, and later for refraction, whether they are having myopia, whether they are having astigmatism, or whether they are having amblyopia, or whether they are developing squint or retinal detachment. We need to keep a watch till the baby is 2 years, 5 years, going to school. So we need to follow them up for a very long time. Especially this strict uninterrupted follow-up is mandatory in ROP, is for medico-legal aspect, and when we have injected the baby with anti-VEGF. This is very, very important. ICROP classification, third edition, tells us about the reactivation of the disease. It tells us about the regression in patients who have been lasered or where there is natural regression of the disease. And also talks about something called as the persistent avascular retina in the periphery, either in the extreme temporal periphery or in the periphery. So this area, if you find it even after 44 weeks, 45 weeks, should be lasered. Otherwise, may lead to retinal detachment. So screening, when we have to stop, is a very crucial issue and a very thin line between the medico-legal aspect and the clinical judgment. So we have to be again very, very careful. Parent counseling. So these are most of the babies who have been, who did not come for follow-up and have landed in almost stage 4, 5. And we had to refer them for surgery and with poor prognosis. So we have to acknowledge them. We have to help fight their fear and be there with them in their grief. We have to remove the parental guilt and also not give them any false hope. We emphasize them with the help of vision rehabilitation and give them support for occupational rehabilitation. And we build trust, which is very important for regarding the medico-legal aspects. So ROP is one of the few causes of blindness where prevention is better than cure. Now, oxygen monitoring, that is judicious oxygen use, timely screening is very, very important. So most of the times we also have mass screening so as not to miss, or universal screening so as to not to miss any baby in the NICU, either because of the nurse or because the baby was absent that day or never came for follow-up, something like that. So prevention is better than cure. So we have to really emphasize on screening. It is very important. And coordination between the neonatologist, ophthalmologist, the nurses, and parents helps build a team approach or a teamwork and prevent blindness in these small babies. So it is a teamwork. It is not a work which can be done only by an ophthalmologist or only by a neonatologist. We have to take consent from the parents, also consult the neonatologist in house, and approach the nurses, coordinate with them as to when we are coming for screening, what is the time, put the dilating drops in proper time, put the proper drop so that the baby is dilated well, so that we do not miss any screenings and we do not miss any baby which is landing into RO. So the take home message is ROP is preventable and timing is very important. So for the PGs, again, few lines which I would like to highlight is childhood blindness. This cause ROP is a preventable cause of childhood blindness. If detected early and managed timely, we can prevent. ICROP third edition standardizes staging, improves communication amongst clinicians. Laser remains a mainstay but requires expertise to avoid complications. Anti-VEGF has revolutionized treatment of zone 1 ROP with superior visual outcomes and less morbidity. Surgery is complex but effective in retinal detachment stages. Comprehensive care includes parent counseling, rehabilitation, and systemic NICU improvements to reduce the incidence of oxygen fluctuations and complications. So, NICU improvements is a must. Close follow-up after anti-VEGF is critical due to risk of reactivation. I would like to also add a point that this is a very good topic for research. There are many heads where you can take up for research in retinopathy of prematurity, especially when AI is coming up. The predictability value of ROP, of development of ROP in a given child, or association of myopia. So there are many research topics with ROP and AI which are coming up, and you can also take for the PGs especially. So it is not just to treat the disease, but to predict which preterm babies will develop severe ROP and long-term myopia. So our care can shift from reactive treatment to preventive evidence-based management. Thank you. Thank you for your patient listening.
Thank you, Dr. Reshma. So that was a wonderful talk. You beautifully highlighted all the aspects of retinopathy of prematurity. You gave us the overview of the updated classification and nomenclature, the very good overview of the treatment modalities, tips on examining the babies, and you highlighted the importance of counseling. That is extremely important. So with that, I congratulated you on your talk, and I think you shared some very, very pertinent points. With that, we move on to our discussants. And first of all, I'd like to bring in Dr. Dhanshri Ratra from Shankar Nethralaya. Ma'am, you have a vast experience with ROP, so anything that you'd like to add to this presentation? And one thing that I'd like you to touch upon is that how are the screening guidelines in India different from the Western countries? You know, in India, we screen for heavier and more mature babies, so something about that.
Yeah, yeah. Thank you very much and a wonderful talk, Dr. Reshma. Very nice. You covered all the points very nicely and you have stressed on the important points. Regarding this, the screening that you are talking about. So in India, we see ROP in a much heavier babies. So as compared to the West, where the ROP is seen in younger babies and also smaller babies, like birth weight less than 1200 or 1000 grams. But here in India, we see sometimes ROP even in if the babies which are more than 2000, like more than 2 kgs, or sometimes even the babies like almost 3 kgs. And also it is seen in more older babies, like beyond 35 weeks also sometimes you see ROP. So even if you have these guidelines, of course you should follow the guidelines and strictly screen all the babies which fall in the guidelines. But also sometimes you have to screen babies which are not exactly in the guideline. They are older babies, but they may have had a stormy neonatal course. So it is good to screen, and you will often see the neonatologist will send these babies for screening as well. So it is not bad to screen these babies. Sometimes you may detect ROP in these babies also. And only one thing I would like to caution is that she discussed very well about the pros and cons about the anti-VEGF injection. And there is somehow there is now the trend of giving anti-VEGF monotherapy, which I feel should be with caution, because as Dr. Reshma also mentioned, there is a chance that the patient can come, the child, baby can come with a late recurrence of ROP. So you have to be very, very careful. If you feel that the parents are not going to follow up regularly, then it is better to do laser in such babies. Thank you.
Thank you. Thank you, Dr. Danshri. So any of the other panelists, if you'd like to offer any more perspectives or comments. Dr. Mukesh, please.
Yes, very nice talk, Dr. Reshma ma'am.
Thank you, sir.
Serial documentation and recording the extent of ROP over the few weeks of follow-up is very important, and preferably with retinal pictures if possible. Ultra-wide field pictures, if it is possible, all the better. But otherwise, also hand drawings and serial follow-up is important for the parents to understand that how it's going and how soon. Sometimes we have to call the patients a few days or every week or so they feel a little bit annoyed and vexed, but the pictures do help.
Thank you.
Dr. Tinku, I had a couple of points
Yes,
to
please.
add on to the very well described talk. In practical purpose, as an ophthalmologist, when we are screening, I think there's 3H, it's something which we need to remember: the hypoxia, hypoglycemia, and hypothermia, which we have to be constantly aware of in spite of baby being in OPD. It might look stable, but these 3H we should constantly monitor. And when it came to ICROP3 classification, which she has already mentioned, just adding on to that, they have already, ICROP3, they have already, added on to the definition of reactivation and regression. So when you are mentioning it in your documentation, please do mention, is it completely regressed or incompletely regressed, or if it is a reactivations post anti-VEGF or reactivation post laser, reactivation into what stage. So all those details needs to be mentioned when you are documenting. So that was something addition which needs to be remembered in ICROP3, of course, along with mentioning the presence of knots and addition of zone 2 posterior, which has been added in ICROP3, which was not there. There was only zone 1, zone 2, zone 3. Now they have added on another subcategory of zone, which makes more sense now. So when you are mentioning any particular finding, just don't mention it as zone 2, to add on what a subcategory it falls into.
Okay.
So very nicely mentioned table in ICROP3 article. I would recommend everybody, especially postgraduates, to go through the article, at least the table, which has summarized very well the new additions of ICROP3. Thank you.
Thank you, Dr. Shushma. Some very pertinent points that you highlighted. So Dr. Abuli, I would request you for your comments.
Very excellent presentation, Mrs. Reshma. So apart from that, already what Dr. Sushma told, from the post-graduation point of view, I would just ask the postgraduates to focus on the recent studies. For example, the aflibercept studies, which are the firefly and the butterfly trials, and apart from that, they should always be well versed with the beat ROP study. These are the commonly asked questions from the exam point of view. And also nowadays it should people should very well be clear that APROP is a term of the past. It's now only aggressive ROP. So that is something which the examiners might ask about, the difference between the old terminology and the current terminology. And also people should be very well averse about the KID ROP model. And apart from that, everything else has been already covered, so there is nothing much from my end. Thank you.
Dr. Tapas, anything you'd like to highlight? Dr. Tapas? Okay, I think he's not logged in. So one more question to the panelist is that when do you recommend lasering, posterior to the ridge? That's another question. When the PGs say that we laser till the ridge, do you also recommend lasering beyond the ridge? Dr. Dhanshri?
Yeah, I think, Dr. Rinku, thank you. I personally actually don't recommend lasering posterior to the ridge because I feel that there is a risk of developing fibrosis if there is an already a lot of fibrovascular element is there. But there are some some ROP people, they do laser, just about one line of laser can be given posterior to the ridge. So, but I would rather ask everybody else's opinion on this.
Anyone else has a differing opinion? Yes,
Yeah.
Dr. Mukesh.
Sometimes there are few proliferations posterior to the ridge, the so-called popcorns. And if they don't regress with the anti-VEGF, then you probably need to go a little bit posterior, even 2 rows or so. Otherwise, they may start proliferating again.
So we have another question in the chat box that the diagnosis of plus disease remains mostly subjective. So in your practice, how do you, get about a uniformity in diagnosing plus disease? What may appear plus to someone may not appear. So any tips and pointers to diagnose plus disease by the panelists? Because there's a lot of inter-observer variability that we see.
My only advice is the most important thing is once the child starts crying or after prolonged crying, even a dilated tortuous vessel sometimes might appear constricted. So it's always important to first look at the posterior pole and the vessels near the disc. That's the giveaway, and that's where the plus disease is picked up. So as soon as people sometimes start looking at the periphery, but ideally you should start looking at the posterior pole. And the moment you see before the child starts crying vehemently, if you see the dilated tortuous vessel, then I think most probably that's where plus disease is identified.
So with that, thank you for that comment.
Dr.
And
Tinku,
with
I just
that,
need to add
yes.
that it is not going to be completely subjective now. They're coming up with plus score. There are grading of plus with like diabetic retinopathy with the picture model.
Yes, yes.
We do have, I think the initial thing has been published on one of the journals. So we do have an objective way of categorizing the dilatation and tortuosity of the
I
blood.
think with AI integrating into systems, I think that will be the way forward to diagnose plus disease in future. So just before we move on, Dr. Dhanshri, you had her poster at VRSI where you talked about risk factors for development of ROP-like picture in older infants,
Yes.
in full-term infants actually. So could you just give
Yes,
us a quick highlight on that? That was a very interesting poster.
Yes, actually, I did not touch upon that previously because I thought this is a program for
Yeah,
post-graduation,
just a quick
postgraduates who
pointer,
better,
yeah.
because they will get confused. But there are certain instances where, as I mentioned, you can see ROP in even term infants on who are like little older and also heavier babies. Various risk factors are there. We really do not know what exactly are the reasons. It's quite a gray area and not everybody agrees on that. But as Dr. Sushma also said, that you have to look at all this hypoglycemia. So many maternal factors are there: maternal diabetes, hypoglycemia, thyroid disease, and even fetal neonatal risk factors are also there. So there is a huge list of risk factors. You may have to look at all the risk factors, but there is a concept of universal screening, which Dr. Reshma also touched upon, where the concept is that you screen all the babies that are born, irrespective of whether they are prematurely born or normal term, so as to try and catch this ROP or ROP-like diseases, if at all. So there are 2, 3 publications are already there. One is from Anand Vinekar, one is from Tapas also. And probably that would be a good concept in order to
I
catch
think.
these very rare
Yeah.
conditions, but yes, they can be there.
Thank you. Thank you so much. So I think ROP is something that so there's
I
a
just
question.
also wanted to add on to the very important point, I think, which we did not discuss, especially when we are using anti-VEGF in ROP, is persistent avascular retina, which all of them have to know, and what is the definition of significance of persistent avascular retina, how to manage it and when to intervene. And that's a separate discussion,
yeah, I
but
think for
they
people.
need to be aware of this terminology called PAR, which is persistent avascular retina, and the details on it. Yeah.
We have another question. What is your recommendation for fundus imaging and documentation of ROP babies for someone starting a new setup? So, any takers for that question? Someone who's starting off. Yeah, Dr. Reshma.
If they are starting a new setup, it is and if you're having an access to the fundus imaging camera, definitely you should go ahead for it, because you can see the periphery well, and of course document the central vessels also, as discussed earlier.
Thank you. I think we've had a very great discussion on retinopathy of prematurity, and now we'll move on to our second talk. That is by Dr. Vijay Pratap Singh Tomar, who's a consultant at the Autonomous State Medical College, Hardoi, and he'll be speaking on white dot syndromes.
Thank you so much, madam. So, good evening, everybody. Thank you so much, AIOS, for giving me this opportunity to interact with the brightest minds of our country, that is our budding ophthalmologist. So, now we are going to discuss white dot syndromes, which is considered as an enigma regarding its diagnosis and the management protocols. So, white dot syndrome is a group of ocular disorders which is characterized by the presence of whitish lesions in the choroid or retinal pigmentary epithelium and or neurosensory retinal layers. And it is having a constellation of various presentations in the form of acute posterior multifocal placoid epitheliopathy, that is APMPP. It can mutes, serpiginous choroiditis, multifocal choroiditis, and panuveitis, punctate or choroidoretinopathy. Then subretinal fibrosis and uveitis syndrome, acute retinal pigmentary epitheliitis, which is also known as Still's disease, then azure, diffuse unilateral subacute neuroretinitis, and bloodshot chorioretinopathy. Now coming one by one. APMPPE, as the name suggests, is an inflammation of choroid and retina, which is characterized by the presence of placoid lesions lying beneath the retina, and the disease is usually seen in between the ages of 20 to 40 years with a mean age of presentation of 26.5 years. There is no sexual predilection. That means that the disease affects male and female equally, and there is no racial predilection also. It has been also found associated with HLA-B7 in 40% of the patients, whereas HLA-DR2 has been notified in 57% of the cases. Delayed type 4 hypersensitivity has been associated with APMPPE, as the disease has been found in association with thyroiditis, scleritis, systemic vasculitis, and erythema nodosum, which are known autoimmune diseases. There are certain case reports regarding APMPPE presentation after vaccination, especially with varicella vaccine, swine flu, hepatitis B, and meningococcal C conjugate vaccine. APMPP not only closely mimics with the white dot syndromes, but it also closely mimics with non-inflammatory conditions like multifocal choriocapillary infarcts caused by hypertension, toxemia of pregnancy, or disseminated intravascular coagulation. Patient usually present with sudden blurring of the vision in both the eyes, and the history of prodromal illness in the form of influenza-like illness is seen in about 50% of the cases. The disease is usually bilateral in nature, but sometimes what happens, the disease comes first in one eye and it takes several weeks to show the presentation in the other eye. Mild anterior segmental reaction can be seen in few cases, whereas vitritis is usually absent in majority of the cases. On fundus evaluation, as the name suggests, you can see here that there are multiple round circumscribed flat lesions which are placoid in nature. And if you will see here very carefully, they are 1 disc diameter to 2 disc diameter in size, lying at the posterior pole, and they are, if you will see carefully, they are extending to the periphery. Optic nerve involvement has been noticed in many of the cases, whereas CME is not that much common. Usually, the disease is self-limiting and it resolves within 2 to 6 weeks, and they resolve and replaced by the scattered area of permanent depigmentation and fine to coarse clumping of the pigmentary epithelium. FFA, in almost all choroidal diseases, we will get early hypo and late hyperfluorescence. So in APMPP, the same pattern is there, that early hypofluorescence is because of the blockage corresponding to the lesion, and that hyperfluorescence is because of the staining. And the lesions, if you will see here carefully, on fundus evaluation, they are fewer in numbers, but if you will see here, they are so many in comparison to what we are seeing clinically. In the inactive stage, since RPE is getting affected, we are going to have patchy hyperfluorescence because of the RPE atrophy and the depigmentation. ICG, again, we are seeing hyperfluorescence both in the active and heal lesions. And here, if you will see, the lesions on ICG are much more than in comparison to what we are seeing on our clinical evaluation. The disease is self-limited and spontaneous recovery is noted in majority of the cases. But poor visual prognosis has been noted when the fovea is involved, or if the patient is of older age group, or the disease is presenting only in the one eye, or there is a longer interval between the initial and fellow eye involvement. If the fovea is involved, there are certain reports that steroids can be instituted, but that is really debatable because 80% of the cases achieve a visual acuity of 20/40 or more without any intervention. Multiple evanescent white dot syndrome is an idiopathic clinical entity characterized by the tiny dots present subretinally, and the average age of presentation of these patients is 28 years with a range of 17 to 7 years. The disease is much more common in females, and like APMPPE, viral prodrome is seen in about 50% cases. Anterior chamber reaction can be seen, but mild vitreous reaction is seen in about 50% of the cases, along with the diffuse choroidal thickening. If the optic nerve involvement is there, then afferent pupillary defect can be detected. The disease is usually unilateral, and as the name suggests, on the fundus evaluation, you can see here that tiny dot-like lesions are there around the fovea and also around the disc. These small dots are actually made up of micro dots, and they can be better appreciated clinically by the means of slit lamp biomicroscopy. And uniform macular granularity is the pathognomonic of mutes. Fundus fluorescein angiography helps us a lot. In mutes, we see early hyperfluorescence, which is patchy or punctate and gives a typical retinal-like configuration. And these lesions show deep staining. And if the optic nerve inflammation is there, we will also see optic disc hyperfluorescence. ICG is suggestive of multiple small round areas of hypofluorescent spot in early and the late phases. And if we will see them on the ICG and FFA, they are much more in numbers than what we are seeing clinically. If optic nerve head is involved, we will see enlargement of the blind spot apart from the central or secocentral or arcuate scotomas. And on electroretinography, we will see early receptor potential amplitude profoundly decrease along with the ERP regeneration time, which is prolonged. If optic nerve dysfunction is present, we will see prolonged latency and decreased amplitude of P100 complex. And this mutes is self-limited, and almost all patients regain visual acuity of 20/30 to 20/20 within 4 to 8 weeks. Serpiginous choroiditis is a bilateral, chronic, progressive, recurrent inflammation of the choriocapillaries and the choroid, and the disease usually affects the age group of 30 to 60 years. There is no sexual predilection. The disease is much more common in whites, but serpiginous choroiditis is very, very common in our subcontinent. Patients usually presents with the blurred vision, metamorphopsia, and central or paracentral scotoma. Anterior chamber is usually quiet, but sometimes non-granulomatous anterior uveitis can be seen particularly in our subcontinent. Mild vitritis can also be noticed in some cases, but if the level of vitritis is a little more, think that it is a case which is serpiginous like choroiditis. On fundus, we will see irregular grayish-white lesions, which are creamy and fluffy in nature. Previously, serpiginous choroiditis was known as geographical helicoid peripapillary chorioretinopathy. And as the name suggests, if you will see here, the disease process is starting near the disc and then it is running centripetally or centrifugally in a serpentine or a pseudopodial manner. And you can see that the active lesions here, they are at the edge of the healed lesion. And healed lesion, we can see here extensive chorioretinal atrophy. And later on, they interlock with each other in a polygonal pattern. Serpiginous choroiditis is having two variants. One is amphigenous choroiditis, which mimics placoid lesions of APMPP and coalesced lesion of serpiginous choroiditis, whereas persistent placoid maculopathy is the other variant. Actually, it is a resistant form of serpiginous choroiditis and resembles maculous GHPC, but differs in its clinical course and effect on the visual acuity, as majority of these patients develop CNPM. Fundus autofluorescence is a very good tool to assess whether the disease is active or it is healed. Active lesions here you can see they are fluffy, but on fundus autofluorescence, if you will see, it is showing hyperautofluorescence. And here where the lesions are healed, here you will see that lesions are hypoautofluorescent in nature. So fundus autofluorescence is a very, very good tool, not only to assess the disease activity, but also it helps us in assessing the response to the treatment. As the lesions are healing, they are getting hypoautofluorescent. Fundus fluorescein angiography shows early hypofluorescence and late hyperfluorescence. And in active phase, we will see the mottled hyperfluorescence because RPE is destroyed. So we are getting this hyperfluorescence because of the window phenomena. ICG is characterized by the hypofluorescent areas from early to late phase, which is actually indicative of non-perfusion of the choriocapillaries. On OCT, we are going to get active lesions are characterized by hyperreflective area in the outer retina, whereas inner retinal layers, they are not involved, they are intact, and there is no sign of retinal thickening. If you will do perimetry, you will get absolute scotoma when the disease is active, but relative scotomas are present once the disease is resolved, corresponding precisely to the visible fundus lesion. Systemic steroids, immunosuppressive drugs, and biologics are the cornerstone of the treatment of serpiginous choroiditis, and if CNVM is present, anti-VEGF use is warranted. Multifocal choroiditis and panuveitis is characterized by the choroiditis along with the intense reaction in the anterior chamber as well as in the vitreous, and the disease usually affects females more than the males and in their mid-30s. The disease is usually bilateral in presentation and patient usually complains of blurred or decreased central vision along with the scotoma and photopsia. If we will see the lesions, they are round to oval yellow, gray in nature, seen at the level of RPE, is scattered throughout the posterior pole and mid-periphery. But these lesions have a distinct propensity for a peripapillary and nasal, mid-peripheral and peripheral distribution. Optic disc involvement is seen in more than 1/3 of the cases, and on fundus fluorescein angiography, as I have mentioned earlier, almost all choroidal lesions except few are hypofluorescent in early phase and hyperfluorescent in the late phase. ICG in multifocal choroiditis is very helpful and very characteristic. If the lesions are active on ICG, they appear hyperfluorescent, whereas healed lesions appear hypofluorescent. But before diagnosing the case of multifocal choroiditis with panuveitis, always rule out tuberculosis, syphilis, presumed ocular histoplasmosis syndrome, DUSN, punctate out a retinal toxoplasmosis and viral retinitis as they closely mimics multifocal choroiditis. And if it's a case of multifocal choroiditis, steroids, immunosuppressive agents, and biologics are the mainstay of the treatment. And again, if CNVM is there, we will have to use anti-VEGF. Punctate inner choroidopathy is a heterogenic group of disease which mainly affects young myopic females of 20 to 30-year age, which presents with blurred vision, photopsia, scotoma, and metamorphopsia. Usually, disease starts unilaterally, but more common presentations are seen bilateral. Lack of anterior uveitis and vitritis is the hallmark of PIC, and we will see multiple discrete flat yellow round lesions at the posterior pole with little amount of subretinal fluid around them. With the time, they fades away, leaving atrophic chorioretinal scar. Absence of cystoid macular edema or disc edema as opposed to multifocal choroiditis or mutes is a characteristic feature of punctate inner choroidopathy. But the most significant clinical sequelae of PIC is the presence of CNVM in about 17 to 40% of the cases. FFA again is very much helpful in punctate inner choroidopathy as the lesions appear hyperfluorescence in their early stage. Once the lesions are healed, because of the transmission defect, they appear hyperfluorescent. ICG again is hypofluorescent in early, mid, and late phase. It has been hypothesized that PIC and multifocal choroiditis are the two ends of the same spectrum of the disease because both are found to be positively associated with interleukin 10 haplotypes and negative association with TNF alpha haplotypes on genome-wide linkage studies. In majority of the cases of PIC, no treatment is required until unless that fovea is affected. But if CNVM is present, we will have to take care of the CNVM either by the means of laser photocoagulation, PDT, or anti-VEGF. Subretinal fibrosis and uveitis syndrome is a very, very uncommon entity which usually involves young myopic females of age less than 35 years and mild to moderate anterior chamber and vitreous reaction is present in these cases. The lesions are usually white to yellowish, round discrete with soft indistinct border with or without neurosensory detachment because of the presence of subretinal turbid fluid, and with the time they fades, they coalesces with each other and leaves a punched out atrophic lesions forming a stellate zone of subretinal fibrosis. FFA again is very much helpful here because lesions here are hyperfluorescence in their early stage, and on electrophysiology we will get an abnormal ERG and EOG. But subretinal fibrosis can be seen in other inflammatory and non-inflammatory conditions like serpiginous choroiditis, onchocerciasis. Despite aggressive management with steroids and immunomodulators, the visual prognosis in subretinal fibrosis is extremely poor. Acute retinal pigment epithelitis is commonly seen in males in the age group of 20 to 40 years, and it can be unilateral or bilateral. Patient usually presents with acute visual disturbance along with the unilateral blurred vision or metamorphopsia, and anterior chamber and vitreous is almost always quiet. On fundus evaluation, if we'll see carefully, there will be discrete cluster of small dark gray spots at macula, and each spot is surrounded by a yellow halo light zone. Since macula is involved, Amsler grid test is very helpful and it shows us central metamorphopsia or scotoma. On OCT, we will get disruption of photoreceptor IOS junction along with wider disruption of the RPE inner band. Fundus fluorescein angiography is having typical findings for the Crin's disease. They show hyperfluorescence of the dark gray spot and that halo that appears hyperfluorescence in the early stage. Later on, this hyperfluorescence gets fade up. ICG shows patchy macular hyperfluorescence in early and mid phase, and hyperfluorescent halo with a pocket-like appearance of macula is noted in the late phase. When the disease is self-limiting, it resolves within 6 to 12 weeks with good visual prognosis. Azure is a very uncommon is a very uncommon disease which is usually seen mainly in the females with a mean age of presentation of 36 years. The disease is more common in Caucasians, followed by the Asians, and there will be a history of viral prodrome or headache or pregnancy in most of the patients. The classical presenting symptoms include acute onset of visual loss, photopsia, scotoma, and abnormal ERG findings, often in the context of a normal looking fundus or ocular examination on initial presentation. 90% of these patients shows a normal presentation, but mild depigmentation of or RP-like fundus changes had been noted in 10% of the cases. The most common visual field defect is the enlargement of blind spot, which can be present or without central scotomas. Fundus autofluorescence is very much helpful in Azure. The zone of hypoautofluorescence is noted with well-defined boundaries, which can be hyperautofluorescent, or there will be a cluster or scattered coarse granular regions of mixed hypo and hyperautofluorescence. ERG is a very good tool to detect Azure, but full field ERG should be done in place of multifocal ERG because multifocal ERG fails to detect peripheral field loss or rod-only attenuation of the retinal function. It presents in the two forms, cone dysfunction and the rod dysfunction. And on ERG, if we will see, there will be decreased reduction in the amplitude and delay in the implicit time of A and or AB both waves in response to the respective stimuli for the cone and rods. Ardence ratio is found to be decreased or extinguished in almost all the cases of primary and mixed cohort of primary or consecutive Azure. And before diagnosing a case of Azure, always rule out TB, syphilis, sarcoid, and viral entities. The effect of systemic steroids and antimicrobial therapy in the management of Azure is a little dicey, but should always be tried where vision is continuously declining. DUSN is caused by the nematode Ophidascaris, Polydelphis, Travus ascaris, and Hexametra, and commonly seen in the children and young adults. It has two clinical stages. In the early stage, we will see the inflammatory sign in the form of papillitis, multifocal chorioretinitis, and mild to moderate vitritis. Whereas in the late stage, it is characterized by the presence of narrowing of vessels, optic nerve pallor, and focal or diffuse changes in the RPE. That fundus fluorescent angiography is not that much diagnostic, and this condition should always be treated with the high dose of albendazole. And if you can see a live worm, it should be destroyed by the means of laser photocoagulation. Now, the last one, birdshot chorioretinopathy. This disease is not commonly seen, is not present in India and commonly seen in the females of North European descendant. And actually, 829 is found to be positive in 90% of these patients. The disease initially presents unilaterally, but with time, it always involves the other eye. Patient usually presents with the history of photophobia, photopsia, glare, and some degree of night blindness, along with acquired blue-yellow dyschromatopsia. Anterior chamber reaction is present, but presence of KPs and posterior synechia is almost rare. Low-grade vitritis is almost always present, and as the name suggests, birdshot chorioretinopathy, the lesions looks like bird droppings, and the lesions are always having a long axis which is radial to the optic disc throughout the post-equatorial retina. Here you can see. And they can also present as retinal vasculitis, predominantly involving venules, CME, and disc edema. On FFA, we can see quenching of the vessels, that is venous hyperfluorescence, extensive late intraretinal and disc leakage. On ICG, there is hypofluorescence and they appear as fuzzy choroidal vessels, indicates activity. We will get B wave reduction in amplitude and increase in latency on ERG along with the abnormal EOG, and dark adaptation threshold is found to be elevated in all these patients, and the treatment is steroids or immunosuppressants. Now, summarizing them. For PGs, you will have to remember certain points. So you will not have to cram. Acute retinal pigmentary epithelitis is more commonly seen in males. In females, mutes, multifocal choroiditis and panuveitis, subretinal fibrosis and uveitis syndrome, and azure is more commonly seen. Rest of the other white dot entities, they are not having any gender predilection. Mutes, azure, and DUSN, they are usually unilateral. Rest of the disease can present unilaterally or bilaterally. If vitreous reaction is present, you will have to think out mutes, multifocal choroiditis, birdshot retinochoroidopathy, subretinal fibrosis, and uveitis syndrome. If no vitreous reaction is present, think about APMPP, serpiginous choroiditis, PIC, and Krill's disease. As I have mentioned earlier in my talk, that for the choroidal lesions on FFA, we are going to see early hypofluorescence followed by late hyperfluorescence. But in multiple evanescent white dot syndrome, PIC, acute retinal pigment epithelitis, and subretinal fibrosis and uveitis, we are going to get early hyperfluorescence. So you will have to remember these 4 conditions. If you are seeing early hyperfluorescence on FFA and you are suspecting it's a choroiditis, think about these 4 conditions. On ICG, you are getting hyperfluorescence in multifocal choroiditis and acute retinal pigment epithelitis. Fundus autofluorescence is a very good diagnostic tool for serpiginous choroiditis and azure. It helps us in not only diagnosing, but also assessing the progression of the disease. And electrophysiology should always be done before branding a condition azure or birdshot chorioretinopathy. So the take-home message is that yes, white dot syndrome is a diagnostic challenge, but with the help of ancillary testing, we can detect them, and treatment is actually based upon the cause and its sequelae. On this GuruSangam episode, I would pay my heartfelt gratitude to my mentors, Dr. Jyotirmay Vishwas, Dr. Sudha Ganesh, Dr. Amla George, Dr. Sudarshan, Dr. Suchitra Pradeep, and Dr. Parthu Pratim Datta Majumdar, who has taught me the nuances of uveitis. So thank you so much.
So, thank you, Dr. Tomar. That was a very well illustrated talk, very beautifully presented, and I especially liked your the slides, the concluding slides, where you summed up everything so very concisely and briefly. Rolika, would you like to ask the discussants to join in? Okay, so I'll carry on. So over to the discussants. Anything that is that you'd like to add to this? I'll start with Dr. Porwal. Dr. Porwal.
Yeah, I think Dr. Tomar has extensively discussed all the possibilities. Maybe there is a distinction to be made for serpiginous versus serpiginoid choroiditis, because serpiginoid is more multifocal, true white dot-like appearance may be there, and infective etiologies are grouped under serpiginoid, I suppose. And otherwise, he has extensively discussed most of the things except the treatment part. I think steroids will be mainstay of treatment in these cases in many of the non-infective conditions, because some of them are autoimmune, but probably it will take another separate discussion for them.
Dr. Obuli, your comments, please.
Very excellent talk, Dr. Vijay. From my side, I would just like to reiterate to the people that in India, serpiginous choroiditis, we need to more think about SLC, which is the serpiginous-like choroiditis, which is majorly seen in especially the North Indian population. Apart from that, every other diseases has been already very well described. So nothing to add from my side.
Dr. Shushma. Dr. Shushma.
Very well presented talk, Dr. Tinku. I think very well covered. Nothing from my side either.
Moving on to Dr. Dhanshri. Dr. Dhanshri, I would like to ask you that what are the common diagnostic errors or pitfalls that you see residents making when they are dealing with a case of white dot syndromes? Something that they should be knowing about. Some common mistakes.
Excellent talk, Vijay. Really very well illustrated and very well summed up. You have covered every entity and you have given all the salient points of each entity. So I am not basically uvea specialist, but there is a lot of overlap between uveitic entities and the retinal entities. The common mistake which I feel the residents can make or do make is that they do not examine the eye properly. I mean, here I would like to stress the importance of doing slit lamp examination. So sometimes they just neglect seeing the slit lamp, and you must put every patient on slit lamp, look for anterior chamber flare cells, look for vitreous cells before say that there is no uveitis. And secondly, when they see the fundus also, you have to learn to describe the finding. You don't go in immediately try put a diagnosis or put a label to that. Like if you see some white dots, you don't just immediately go and label, oh, this is serpiginous, this is not. Some cases will be very typical and you will be able to diagnose immediately. Other cases will be very there may be overlap and may be very confusing. So try and see the image, see the lesion, and like Dr. Vijay just now elaborated, you see what is the distribution of the spots, or how is the size and where they're situated. And then the ancillary examinations, investigations like FFA and ICG also, you need to interpret it very well. So learn all these interpretations so that it will help you in your clinical diagnosis. And you have to go in a very systematic manner in order to come to a diagnosis in uveitis, because it's very complex. As you already saw, there are so many entities. It will be very complex. So you need to know the salient points of each, and you need to look for all those points which Dr. Vijay mentioned, so that if you go in an orderly fashion, you will be able to come to some diagnosis. And when you order investigations also, you need to tailor the investigations. You can't order a battery of tests for each and every case. So you need to for you to order the investigations, you need to know what exactly it is that you are focusing on. So I think Dr. Vijay has explained very well. I don't have any further to add for uveitis
Thank
point
you.
of view.
Thank you, Dr. Vijay. I think the mind sees only what it knows, and you've shown such excellent clinical pictures and differentiating points for all the uveitic entities. I think the residents will be able to diagnose and pick up these white dot syndromes better. Before we move on, just a last question to you, that which would be the most common white dot syndromes in practice that the residents should watch out for? The top 3 to 4.
In Indian subcontinent, if you'll ask
Yes,
me,
yes, in India.
serpiginous choroiditis should always be ruled out. And as the other panelists have said, it should always be differentiated with serpiginous-like choroiditis. Serpiginous choroiditis, the element of vitritis is almost always missing. But in serpiginous-like choroiditis, the element of vitritis is present. The second thing is that serpiginous-like choroiditis, these lesions are actually multifocal. And if you are seeing multifocal lesions of serpiginous nature and you are seeing vitritis, always rule out tuberculosis in a country like ours. So this is a very, very common entity. Then the second one, if I will say, is multifocal choroiditis. It is a very common presentation because there are so many infectious conditions like tuberculosis or sarcoidosis. They also have multifocal presentations. But the element of that vitritis that you will have to look for and the anterior chamber reaction. As the name of multifocal choroiditis suggests, multifocal choroiditis with panuveitis syndrome. So the anterior chamber reaction and that vitreous inflammation that is always present with multifocal choroiditis. In the patients of tuberculosis, the element of that vitritis is not that much common, and tuberculous panuveitis is a little bit uh, uncommon entity. Sarcoidosis, you can get that element of vitritis, but not that much as we see in the multifocal choroiditis. The third thing is to look for the APMPPE. Pramod Gupta sir has a beautiful article on that serpiginous choroiditis. I think I have read that very early. that there were three cases which initially presented like APMPP, but later on they were found to be the cases of serpiginous choroiditis. So while that interpreting that whether these lesions are serpiginous or they are the lesions, they are the placoid lesions of APMPP, or again look for that element of vitritis. To diagnose a case of white dot syndromes, you will have to look carefully the anterior chamber, the vitreous, and the choroid. Then you will have to take the history very carefully, and then you will have to decide, as Dhanashri Madam has said, what investigations you are planning.
Thank you. Thank you, Dr. Toma, for that very insightful talk and that excellent discussion. With that, we move on to our third talk of this episode, and that would be by Dr. Sujata Padhi. Dr. Sujata is a consultant at the MKCG Medical College, Behrampur, and she would be speaking on retinitis pigmentosa. Again, a very relevant and useful topic in our everyday practice as well as for the postgraduates. Welcome, Dr. Sujata. Dr. Sujata, I request you to share your screen. Yes.
Thank you, madam.
Yeah.
Very good evening. I would like to thanks AOS for giving me the opportunity. And my topic of presentation is retinitis pigmentosa. Rubin,
Yes, ma'am, please continue. We can see your presentation.
it's not working. Rubin, sir. Rubin. Down, okay. First introduction. Retinitis pigmentosa is the term used for a group of disorders that are characterized by inherited progressive dysfunction, cell loss, and eventually atrophy of retinal tissue. First, there is initial involvement of the photoreceptor, then that leads to subsequent damage to the inner retinal cells. Then history, it is first Donders defined the term retinitis pigmentosa. Although the retinitis pigmentosa is currently used worldwide, but retinitis, itis means inflammation. It is not the primary cause of inflammation, but it is the genetic mutation which causes apoptosis, and it is the main process of the eye disease. Then, according to Leber in 1916, he gave the definition of retinal degeneration. Retinitis pigmentosa are the most frequently diagnosed hereditary-dystrophic pathologies of the retina and neurodegenerative disorder of the tapetum. Tapetum represents a layer composed by perennial cells named retinal photoreceptors, that is rods and cones. So there are several terminology used for retinitis pigmentosa, that is tapetoretinal degeneration, primary pigmentary retinal degeneration, pigmentary retinopathy, and rod cone dystrophy. Epidemiology, it's the most common hereditary dystrophy, and the prevalence is 1 in 5,000 worldwide. But in certain part of India, in South India, it is mostly the common retinal cause of blindness, and the prevalence is 1 in 750 because of the consanguineous marriage. The males are more frequently affected than females, and it is usually a bilateral condition. Then etiology. Etiology is unknown, but the Sir William in 1902 introduced the term abiotrophies. Abiotrophies means lesion affecting nervous tissue characterized by defective vitality leading to their premature decay determined by genetic influence. So, RP is a abiotrophies in nature and genetically determined. Then the mode of inheritance, it is mostly two types of inheritance. One is sporadic, means there is no genetic influence, and it is 50% is of RP constitute the 50% of RP. No other family members are affected. And inherited, there are three types of inheritance present: autosomal recessive RP inheritance, autosomal dominant, and X-linked recessive inheritance. Then the inheritance pattern in autosomal dominant, in this type of form of RP, only one parent has the gene and is usually affected by the disease. Each child has 50% chances of inheriting these genes and developing RP, and it has best prognosis. Then autosomal recessive, here both the parents are carrier, and the chance of having this condition is higher if the parents are related. And the expression is 25% affected, 50% carriers. And as third is X-linked recessive. It is rarest form and has worst prognosis, transmitted by females and appears in male. And by age of 20 years of age, visual acuity is greatly reduced. If the mother is the carrier, 1 in 2 sons will be affected and 1 in 2 daughters will be carrier. Then genetics about the RP, it is mostly caused by the mutation or in multiple genes. There are more than 100 gene loci are involved. For autosomal recessive RP, autosomal dominant RP, there are 26 specific genes are associated, and for autosomal recessive, there is 57 isolated genes are involved, and there is 3 specific genes are affected in case of X-linked recessive. So the genetic defect affect phototransduction cascade, retinal cycle, photoreceptor structure, and other biological functions of RPE and photoreceptors. So the rhodopsin and the peripherin or RDS mutation is the commonest genetic mutation, and the other mutations in RP, that is GTPase regulator, mutation in ABCR gene, and abnormal pre-mRNA splicing also involved in the RP. Then what is the pathophysiology? Pathophysiology, it is mostly the mutation which trigger apoptosis or programmed cell death of the retinal photoreceptor. First, it affects the rod. Then, apoptosis of rod cells can trigger apoptosis of the surrounding cells. Then, the retinal pigment epithelial cell can detach and deposit into the perivascular area, leaving bony spicule-shaped myelin deposit. The symptoms, it is the onset of symptom and progression depend on the inheritance, the genetic pedigree, and the symptoms are bilateral. Night blindness or difficulty with vision at night, it usually starts at the age of 20 to 30 years, but the earlier or late onset depends on the inherited pattern. And there is disorientation in dim light, so the patients often confused while driving in the night. And the second is visual field defect. There is insidious progressive loss of peripheral visual field, and there is progression of the field. That earliest defect is relative scotoma in the mid periphery between 30 and 50 degree from fixation. Then scotoma first starts at the inferior temporal quadrant. Then it increases to form partial or complete ring. Then the ring scotoma enlarges towards the far periphery, anteriorly and posteriorly. Then lastly, only the tubular vision is left. Then other symptoms include light and glare problem, and in bright sunlight condition there is whiteout, and photopsia or photophobia is mostly development of the cataract. The cataract is mostly posterior subcapsular. Then signs. The signs is the classical triad of fundus finding is there occurs atrophy of the retinal pigment at the mid periphery, and there is bony spicule retinal pigmentation at the mid periphery of the fundus, then arteriolar attenuation and waxy disc pallor. The other fundus finding includes in macula, there is atrophy, epiretinal membrane, and cystoid macular edema, and it is there is myopic fundus present, optic disc drusen is present, and tapetal reflex present, the carrier of X-linked recessive type of RP. The anterior segment involvement findings are there is high myopia and astigmatism. Keratoconus, though rare, may be present, and primary open angle glaucoma is present. And in some form of RP, that is in sectoral RP, there is hyperopia and angle closure glaucoma. Then cataract is present, that it is mostly posterior subcapsular. Then vitreous, there is fine dust-like pigmented cells released from the degeneration of the RP present. There is posterior detachment of the vitreous and cotton ball opacities present at the retrolental space. There is peripheral vitreous hemorrhage related to the pre-retinal neovascularization. Then differential diagnosis or pseudo RP. The differential diagnosis include retinal inflammatory disease like syphilis, rubella retinopathies, and infectious retinitis like toxoplasmosis, and the other drug toxicity which may give rise to RP-like features, that is thioridazine and chlorpromazine, the antipsychotic drugs, chloroquine, quinine, and the traumatic retinopathy, and autoimmune paraneoplastic retinopathy, that is it seen in case of some oat cell carcinoma of the lung or cervical carcinoma. Other is diffuse unilateral subacute neuroretinitis. Then classification of retinitis pigmentosa, they are classified according to the genetic makeup. One is typical RP and atypical RP. Typical RPs are autosomal dominant RP, autosomal recessive RP, and X-linked recessive RP. Then subdivision by age of onset. It may be early onset. Early onset is congenital, and childhood onset, it is juvenile or early adult onset. Then subdivision by fundus appearance, it may be typical RP. There is a typical classical triad of fundus finding present and atypical RP. Then atypical retinitis pigmentosa again is divided into syndromic and non-syndromic. In the syndromic RP, they are associated with systemic features and but in non-syndromic only the fundus finding is different. The atypical RP are retinitis pigmentosa sign pigmento, sectorial RP, unilateral or asymmetrical RP, then retinitis punctata albicans, Leber congenital amaurosis, and pigmented paravenous chorioretinal atrophy. Retinitis pigmentosa sign pigmento, here there is absence or paucity of pigment accumulation which subsequently appear with time, and there is functional manifestation. The functional manifestations are same as typical RP. Second is in punctata albicans, it may be inherited as autosomal dominant or autosomal recessive. There are scattered numerous tiny punctate whitish yellow dots present, and they are mostly present at the equator, sparing macula and associated with arteriolar attenuation. It may be progressive or stationary. Then central or inverse and RP, it may inherited as autosomal recessive or autosomal dominant. The loss of visual field is at 5 and 15 degree of fixation. The pigment depends, coalesce and enlarge, and they encroach more on the central. So there occurs, because the central macula is involved, there is greater disability at an earlier stage of the disease. Sector retinitis pigmentosa. Here the pigment is confined to one sector of the retina, mostly infero-nasal quadrant is involved. So field defect is present at the superotemporal quadrant and the progression is slow. Then pigmented paravenous chorioretinal atrophy. Here it is usually asymptomatic and non-progressive, and the ERG is normal. There occurs paravenous bone spicule pigmentation together with sharply outlined zone of chorioretinal atrophy that follow the course of mesoretinal veins. Changes may also encircle the optic disc, and the optic disc and vascular caliber are usually normal. Unilateral pigmentary dystrophy, it is rare, it is usually acquired condition, and here one eye only shows the characteristic fundus finding and functional disabilities and ERG changes. Then association with systemic disease, that is syndromic RP. There are several syndromes are associated, but the commonest syndrome are Usher syndrome. Usher syndrome, it is inherited as autosomal recessive, and it is usually appear in the earlier age. There is hearing loss along with the visual impairment. There are 3 subtypes are present, and it mostly it affects the vestibular system. So there is valence difficulties. The fundus is described as salt and pepper pigmentation, and the systemic features association are premature aging. There is skeletal deformities, dwarfism, mental handicap, and deafness. Second is Lawrence Moon Bardet-Biedl syndrome. Here there is hypogenitalism, retinitis pigmentosa, mental retardation, polydactyly or hexadactyly, obesity, and skin lesions are present. The other is Bashan-Convict syndrome. It is also known as A-beta lipoproteinemia. Here, the fat and fat-soluble vitamin A, D, E, K absorption is dysfunctional, and a failure to thrive in infancy. A blood smear shows typical thorny red cells called acanthocytosis. Other features include ptosis, ophthalmoplegia, strabismus, and nystagmus. Then Refsum's disease, it is due to phytanic acid accumulation throughout the body. There is skin and neurological and visceral features present. Retinal changes may be similar to RP, or there is salt pepper appearance of the fundus along with there is present cataract and optic atrophy present. The shortened fingers and toes and the low phytanic acid diet can retard the progression. So other syndromes associated are osteoneuroendocrine dysplasia, Cockayne syndrome. In Cockayne syndrome, there is also RP, deafness, dwarfism, progeria, oligophrenia, Hallgren syndrome, and myotonic dystrophy. Then investigation. The investigation or diagnosis is most important because it is a genetic disorder, genetic inheritance. By investigation or diagnosing early, we can retard the progression. So history taking is important. The rate of progression and functional difficulties depends on the inherited pattern and the systemic association. From the systemic association, we can diagnose the syndrome. Family history is important for genetic counseling, and the visual acuity helps to know the extent of the disease. Then color vision testing. Uh, when there is good central vision, there is the color vision is normal, and the involvement of cones give rise to color vision defect, and the color vision is mostly blue yellow blindness. Then diagnostic tools, one is electroretinogram, electrooculogram, perimetry, ocular OCT, and genetic analysis. Electroretinogram, it is the sensitive diagnostic test and helps in detecting the early phase of RP with minimal or absent fundus changes. In early RP, there is reduced scotopic rod and combined response. With progression, photopic response is also reduced. Then there are other types of ERG, full-field ERG, multifocal ERG. They also helps in diagnosing the disease. And electrooculogram, it is subnormal with absence of the light rays. Retinal densitometry or fundus reflectometry, it also helps in diagnosis the disease. Then fundus angiography, it is mostly helpful in diagnosing cystoid macular edema or any macular pathology. Then perimetry or visual field, it is most important test to diagnose and know the progression of the disease. First, there occurs ring scotoma in the mid-periphery. Then it starts as group of isolated scotoma around 20 degrees of the fixation. It coalesces to form a complete ring. Then in late stage, field becomes smaller, reduced, and restricted area around the fixation points. So in long duration, the central vision remains and gives rise to only tubular vision. Then dark adaptometry is prolonged and may be useful in early cases. And OCT is helpful in identifying cystoid macular edema, and the other investigation is genetic analysis to know the genetic pedigree. Then treatment. RP is a genetic disorder, and so there is no cure or no treatment for RP. With diagnosis, we can delay the progression. So the treatment include supportive treatment, and the first we should follow up regularly, and there is no specific treatment is available. But recently, the Luxturna gene therapy is approved for patients with RP65 mutation. It is usually associated with cataract. Cataract develop in RP, so cataract surgery is beneficial. Low vision aid, provision, rehabilitation, and social service assessed when appropriate. Smoking should be avoided. Sunglasses, that is nanometer control to block wavelength up to about 550 nanometer and with side shielding. And the nutritional. Vitamins and nutritional supplements can slow down the process. So the oral vitamin A combined with vitamin E and K, the dose of vitamin A 15,000 international unit daily can be given, but it should given judicially because it causes hepatotoxicity. And low phytanic acid diet is helpful in the progression of the disease in case of Refsum's disease. And the omega-3 fatty acid rich oil fish once a week may be helpful. The antioxidants like lutein and zeaxanthin helps to protect macula from oxidative damage, and the dose is 20 milligram per day. And the docosahexaenoic acid, it can be given 400 milligram day for 4 years, and it is demonstrated that the trial demonstrated a correlation of preservation of cone ERG with RBC DHA level. Then visual rehabilitation is the last treatment in case of in end stage. So there are several researches are going on. The one is gene therapy research. Here, yeah, introducing a healthy gene into the retina. Then stem cell therapy research. Here the stem cells. Stem cells means it is a pluripotent cells capable of differentiating into variety of cell type. And the cell type used are embryonic stem cells and induced pluripotent stem cells and and retinal progenitor. And the route of injection is subretinal and intravitreal. And others are retinal prosthesis. Retinal prosthesis, it is a rehabilitation device. It is an implantable light sensitive electrode. Here the electrode detects the light, then it converts the light energy into electric signals, and the cells in the visual system transmit the signal into the brain, and the vision is perceived. It is introduced into either into the epiretinal position, subretinal position, or suprachoroidal location. This is a one type of retinal prosthesis. It is only FDA approved retinal prosthesis, and it uses an external video camera and processing unit, and the antenna is connected to the processing unit, and the it transmits the impulse to the optic nerve. So the take-home message is, it is the most common retinal dystrophy. 50% cases are sporadic. Nyctalopia and peripheral visual defects are the commonest presenting symptoms. The classical triads are arteriolar attenuation, waxy disc pallor, bony spicule-like pigmentation. Currently, no definite treatment is available, and the recent advance is stem cell therapy, gene therapy, artificial retina can show promising result in future. Thank you.
Thank you, Dr. Sujata ma'am, for that very comprehensive talk where you highlighted all the variants of retinitis pigmentosa, its clinical presentations, as well as new treatment modalities in the offing. So with that, I'd move on. Ma'am, I request you to please stop sharing your screen so that we move on to the discussion.
Ma'am, we have a question.
Yeah,
Can we
Radhika,
ask
please
that
can.
first?
Yes, please.
Ma'am, the question is that what would be your, do you advise vitamin A supplementation by default to all the patients, or you prefer to change the protocol as per the stage?
So I think any of the discussants could take that up.
Bantri ma'am, would you like to discuss that much?
Yes, this is a very relevant question, and not only the doctor but the patient also wants to know whether we can take high dose of vitamin A. But the high dose of vitamin A is not been shown to be of any use, because previously we also used to advise vitamin A to all patients of retinitis pigmentosa. However, a study showed that even after 15 years of vitamin A supplement, there was no much improvement in the retinitis pigmentosa. And secondly, there are certain conditions like, say, cone rod dystrophy or Stargardt's disease. They can worsen with vitamin A supplementation. So unless you have absolutely certainly diagnosed the case, with molecular basis and genetic testing, it is better not to start high dose of vitamin A. Whatever the vitamin A the patient gets from the daily diet is good enough to help the patient. So my take would be to be very conservative and not advise too much vitamin A.
Thank you,
ma'am.
Doctor.
And ma'am, Sushma ma'am, would you like to add the comments?
Yes, I had a couple of points. Very well presented talk. Just to add on to what she has already described, when it comes to differential diagnosis, the most common differential diagnosis when we see is unilateral bony spicule kind of presentation with one quadrant involved. We are very in a hurry to label it as an atypical RP or segmental RP. But one of the common differential is spontaneously reattached retina, which can mimic as a RP. So that's something which we have to keep in mind. And also, not all eyes of RP is going to have this very grand presentation of bony spicules with pale disc. And especially if you're looking into the kids or uh, the patients with a family history, you need to look into the vessels carefully. I think before bony spicules or pallor of the disc, the vessel changes are very, fine and very subtle, and especially the attenuation. Many times the arteries are gone. You can see only vein, which is so much sclerosed, like one line which is going like an artery. So vessel attenuation is something which you have to look in carefully, especially when you're looking into early age groups or those you are or those who have a strong family history. And another important point which I wanted to add is when you're following up a RP patient when they come with diminution of vision, I think we are very fast in labeling that it's a part of the natural progression of the disease, and convincing them that this is what it happens. Before that, I really request all our young colleagues to look into the anterior segment. Cataracts are common. If they have already undergone cataract, there might be a PCO. So just because an RP patient comes with complaining of diminished vision, don't shoo them off telling that this is a progression of the disease. So look into the anterior segment changes because they have tunnel vision. Any minute changes which happens in the center part of the vision, they will have a very significant disturbance than that of a normal eye. So especially if they're coming with a very recent drop in vision which was not there, and please put some effort in knowing the type of diminution of vision, especially you're seeing a follow-up patient of RP. So these were my couple of points. Yeah.
Thank you. Thank you so much, Dr. Sushma. Rolika, any more questions from your end?
If I can add some more.
Rolika, you there? Okay, so any of the other panelists, anything that you would like to highlight in retinitis
Yeah, a couple
pigmentosa?
of points. One
Yes,
for the
please.
PGs and one for the practitioners. There is an interesting autofluorescence finding in RP, which shows the central working area demarcated by a ring of autofluorescence, hyper autofluorescence called the Robson ring or Robson Holder ring. So if you see that, it is diagnostic and as well as an interesting finding to make out if you do an autofluorescence. That is one. The other one is many of these patients have visual fields less than 10 degrees. And that is very important because that itself qualifies them to get a 100% visual disability blindness certificate. Okay, and that then they can use to get other benefits like travel certificates or the bus passes, the train passes, and all that from the government. So maybe we can't do very much in treating them, but we can provide them with these accessory benefits, and that will go a long way. And that comes with the attendant pass also. So not only the RP patient, somebody with them would also stand to gain from these disability certificates. If you can show the visual disability chart, which tells clearly that less than 10 degrees in both eyes qualifies for 100% blindness.
True. So thank you so much. So at the end of this discussion, I'd just like to sum it up that for these patients, it's not a non-treatable disease. We can preserve the macular functions as much as possible by advising less exposure to UV radiations, that is asking them to wear sunglasses or hats when they're outside. By and nutritional supplement, again, I think there's a consensus that there's no role of any vitamin A supplementation or vitamin E supplementation. In fact, vitamin E supplementation can prove more deleterious in these patients. We should we should look at the anterior segment, as was pointed out by Dr. Sushma, and there could be treatable pathologies like cataract, which should be taken care of. We should also make a note of any cystoid macular edema, any other retinal pathologies that can be taken care of. Also, the role of a very good counseling to these patients and the role of genetic counseling so that they know their genetic makeup in future. If there are any treatments that come up, they would know their genetic makeup. And also to give them a very realistic view of the treatment modalities that are coming up. So I think that sums up the discussion. And at the end of this discussion, Dr. Tapas Padi has joined us. He could not join here. I was having some software problems in joining. Dr. Tapas, are you there?
Yeah. Thank
Yeah,
you,
so welcome
Dr.
to the
Tinku.
webinar. So
Yeah,
Dr. Tapas has
and
a huge amount of experience in managing ROP. So we'll quickly just transgress to the previous topic. And Dr. Tapas, any inputs on ROP that you would like to share with us, your experience with in dealing with ROP?
yeah, it's a broad topic. Actually, I
For the
don't know
PGs,
about the presentation.
some pointers for the
Yeah,
PGs that you feel they should be knowing.
so I would just highlight, there are many screening criterias across the world. An easy way to remember is 234 for ROP. So 234. 234 is less than 2 kg, and or birth gestational is less than 34 week, should be screened within 2 to 3 or 3 to 4 weeks of life. So an easy mnemonic to remember, ROP screening and criteria and the time to screen is less than 2 kg, less than 34 week, should be screened within 2 to 3 or 3 to 4 weeks of life. That is my point number one. Point number two is for the students or residents, the disease is 100% curable, provided we detect the disease in time with prompt and adequate treatment. The third point would be laser has been the gold standard, but slowly the anti-VEGF treatment is going up. While the anti-VEGF show a wonderful and dramatic response if they are given in time, but they are associated with a risk of disease reactivation and persistent avascular retina throughout life, so they need to be monitored. That's what the three takes from my side for ROP. I have, if there is a time, I have a quick comment on the retinal dystrophy.
Yeah, please go ahead. Please go
Yeah,
ahead.
so my take is that no, we are shifting from an era of a phenotypic diagnosis to a genotypic diagnosis. We know that a disease, there are two diseases which may look alike, might have a symptom similar, but they are not same. So if you do a genotypic diagnosis, it can segregate and give you a better confirmation, and the best diagnosis is a genotypic diagnosis. Number two, when we do a genotyping, you will see that many additional findings like these genotypic genetic disorders can have other genes affected. So many a times, while confirming one disease, you would have a chance to look for systemic associations. One can catch many other diseases. The third point is genetic disease gives you a clue to what would be the future. So knowing, say, RP2, RPGR, so they have a specific pattern and course over time. One can literally predict what would be the future, what would be the chance of affecting the next generation. So it can have give you a good, strong way to counsel the parents. The fourth one is now the gene therapy coming in. This will keep the patients prepared for a possible genetic therapy in future.
True.
So
Thank you.
whenever there is a chance, one should genotype all these cases.
Thank you. Very well highlighted. So genetic typing should be advised to all patients of retinitis pigmentosa. That would be the take-home message from your comment. And with that, I thank the panelists and I move on to the fourth talk of this episode. That would be by Dr. Rajvinder Kaur. Dr. Rajvinder is from the Adesh Institute of Medical Sciences and Research, Bhatinda. And she would be speaking on vascular occlusions, that is central retinal artery and central retinal vein occlusion. Dr. Rajvinder, over to you.
Thank you, ma'am. I will share my screen. My screen is visible, ma'am?
Yes, it's visible. It's visible, but it's not full screen, Dr. Rajwinder.
Now, ma'am, it is okay?
Yes, yes.
Okay, the topic of my presentation is the central retinal artery and vein occlusion. So first of all, I would like to thank the All India Ophthalmological Society for giving this opportunity. So no financial disclosures, and I would like to acknowledge the various articles of Dr. Hari for his teaching in vascular occlusions. So I will try to cover the relevant anatomy, the salient clinical features, the etiology, and the treatment options and names of different trials done. So as we know that the central retinal artery and the vein, they go along with each other. So that is when we talk about that is the blood supply of the eye, that is from the arch of the aorta, then common carotid artery, then the internal carotid artery, and the central retinal artery, which is an end artery. It originates from the ophthalmic artery. So why there is the sudden vision loss, like the blood bulb is off suddenly, which is a common complaint of the patient, is like that it is the end artery. So patient comes with the very decreased vision, such as the hand movements or PL negative or the PL positive. So the ophthalmic artery, the other branches, that is anterior ciliary arteries and long posterior ciliary arteries and short posterior ciliary arteries, they supply the ciliary body and iris. And the outer retina is supplied by the short posterior ciliary arteries. So we can see here that from the internal carotid artery, the ophthalmic artery arises, and the vein also, they go along with each other. And then the cilioretinal artery enters the optic nerve at the dura. So this is the common site of central retinal artery occlusion, because it is thinnest where it enters the dura, and it is the common site for the lodgement of the embolus. So we can see here that it is the site of the embolus lodgement. But when it is secondly, it can occur at the level of the that is lamina cribrosa also, where the thrombotic part comes into the play. So how it enters the eye and then bifurcates into the arcades, superior and the inferior arcades. So the inner 6 layers are supplied by the central retinal artery, and the outer 4 layers are supplied by the choriocapillaries, and fovea is supplied from the choroidal circulation. So we can see here that is the inner, that is the 6 layers are supplied by the central artery, and the outer 4 layers are supplied by the choroidal circulation from the posterior ciliary arteries, and it is responsible for the choroidal circulation, along with the that is opacified retina in the periphery, which is responsible for the cherry red spot appearance in the central retinal artery occlusion. So the second is the cilioretinal artery. So the branches from the short posterior ciliary artery, that when it enters, it just hooks around the optic nerve head, and it enters there is a second branch, that is the cilioretinal artery, which originates from the short posterior ciliary arteries. And this anatomical variation is present in 15 to 20% of the population. So sometimes in presence of the that is central retinal artery occlusion, the vision is preserved because of the intact cilioretinal artery, and it supplies the varied area of retina. And the fundus fluorescein angiography is diagnostic along with the choroidal circulation, because it is filled during the choroidal circulation, and usually it appears the hypofluorescent, and the dye is filled in the central that is cilioretinal artery before the filling of the central retinal artery. So it is, we can see in the clinical picture, it hook around the optic nerve head. So the central retinal artery occlusions, they are seen in 60% of the cases. And then branch retinal artery occlusion, they are seen in 35% cases, cilioretinal artery in 5% of the cases. And sometimes we have combined central retinal artery occlusion along with the vein occlusion. So what is the pathogenesis behind the central retinal artery occlusions and central retinal vein occlusion? So in the cases of the central artery occlusions, mostly we have the emboli from the heart and the carotid, which is more common, and it is seen in 66% of the cases. The site of obstruction is, as I have already told, that it is at the site of central retinal artery where it pierces the dura around the optic nerve. So here it is the thinnest. So there are high chances for the emboli lodgement. And the less common is the thrombotic component, which is playing in the central retinal artery occlusion due to the atherosclerosis. And site of obstruction is at the lamina cribrosa. But in the cases of central retinal vein occlusion, this part plays the role, that is the thrombus formation due to atherosclerosis. And so there are three components of the virtual striates, that is the stasis, hypercoagulability, and the endothelial injury, which results in the thrombus formation. So there are four types of emboli in central retinal artery occlusion. The cholesterol, that is which constitutes 75% of the CRO, and that is the yellow refractile, and they're usually present at the bifurcation of the arteries. And then it is that is a thrombus, that is made of the platelet, fibrin, plaque, and large mobile, and they can be seen the multiple. Then comes the calcific, that is that they are dull gray and the yellow. They have the worst prognosis. And the fourth can be due to some fat, bacteria, or the tumor. So the causes for the central retinal artery occlusions. So in the old age, it is mostly the emboli from the carotid arteries, atrial fibrillation, and the valvular disease, which constitute the main part in the old ages. Bacterial endocarditis, diabetes, hypertension, hyperlipidemia, and vasculitis. In younger age groups, the patient may have the protein deficiency, CS deficiency, cystic fibrosis, chronic alcoholism, OCPs in most commonly in the females. Then it can happen while giving the retrobulbar injections or the peribulbar block, leukemia, and lymphoma. And when there was mycosis and the COVID-19, we have seen many cases of the central retinal artery occlusion because of the virus-induced coagulopathy. So in Indian populations, there is a study which has shown that is the hyperhomocystinemia were found to be more common in our population of the Indian origin. So how the homocysteine is associated with the vascular occlusion? So there are two pathways which is responsible for the homocysteine metabolism. So that is when it is converted with the help of the B12 and the folate. So it is converted into the methionine. And then that is the second pathway is trans-sulfuration pathway, where it is converted to the because of the high homocysteine, it is not converted further. It can result to the atherosclerosis, endothelial cell damage, which results in reduced nitrous oxide, and prothrombotic component, which results for the thrombotic thrombus formation. And the excessive methionine, as the people are converting to high protein diet, so there can be the excessive methionine which can result in the high homocysteine, which can be responsible for the virtuous striate, resulting in atherosclerosis and the thrombus formation. So how the central retinal artery occlusion affects and how it looks. So acute obstruction of the retinal artery, there will be the secondary collapse of the capillary flow, and there is exoplasmic status and ischemia of the inner retina, which results in the that is nerve fiber layer and the inner retinal opacified. And now what is in the center, that is a cherry red spot, which is diagnostic for central retinal artery occlusion, appearance at the foveola, as it is supplied by the choroidal circulation. So we can see that the periphery outside the macula we have the opacified retina, and in the center the macula is unaffected because it is getting the supply from the choroidal circulation. So it is looking as a cherry red spot. So there are the four distinct clinical entities of CRO by Hare, that is non-arteritic, which is most common, which includes it is the most common presentation, and features include the retinal infarction, cherry red spot, absent or the poor residual retinal circulation. The second is the transient CRO, which is temporary occlusions lasting minutes to hours. Visual outcome depends entirely on the duration of the ischemia. So it has the best prognosis, and that is non-arteritic, that is 67% has the worst prognosis. CRO with the retinal sparing, that is 14% cases, patent ciliaretinal artery significantly influences the visual outcome and the retinal circulation patterns. Then it is arteritis, which is that is the 14% seen in the 4% cases, and it is seen in the giant cell arteritis, and it is associated with the AION and requires the immediate diagnosis and aggressive treatment with the steroids to prevent the bilateral vision loss. So, in the central retinal artery occlusion, a typical case, we can see the cattle truck sign, that is a segmental and the jerky blood flow. And the disc may be normal, pale, and the hyperemic. And with the cherry red spot, the PG can be asked why there is a cherry red spot. And it is because of the intact choroidal circulation. So these were the pictures taken by me only during the mucormycosis, where we see the varied pattern of the central retinal artery occlusion. In the first case, we can see the hemiretinal, that is CRO. Then it's partial with the intact ciliaretinal artery. Then it is the central retinal artery with some atypical appearance. So what can be the investigations which we should do? That is the dilated fundus examination, FFA, OCT, Humphrey, then ERG. So dilated fundus examination reveals the cherry red spot. The peripapillary area may appear swollen and opaque, box carrying of the retinal arterioles. Ambula are visible in 20% of the cases. So over a few days to weeks, the retinal cloudiness and the cherry red spot gradually disappears, although the arteries remain attenuated. Late signs may be the optic atrophy in 91% cases, collateral may develop in 18% cases, vessel sheathing and patchy inner retinal atrophy and the RP changes can be seen in 11% cases. And 2% eyes can have a retinal and the disc neovascularization. So rubiosis iridis may occur in maybe in 5 eyes within 4 to 5 weeks. So optic atrophy. So the mostly that is the segmentation of the blood flow, and the late picture the lower picture is the late picture where there is optic atrophy, the post CRO. On the fundus fluorescein angiography, can be performed in all the CRO eyes to distinguish between the various types of CRO and determine the extent of the central and the peripheral retinal perfusion. So detect the neovascularization, which may occur 2 to 16 weeks after the CRO. So what are the features of acute CRO? That is, there may be the normal choroidal filling, and in arteritic cases, that is, there is a delayed choroidal filling. But in non-arteritic CRO, there may be the normal choroidal filling. A patent ciliaretinal artery will fill during the early phase, during the choroidal phase only, and there is a delayed retinal filling. So hyperfluorescence of the involved area can be seen. So the features of late CRO, that is complete restoration of the retinal arterial circulation within a few days to several weeks of CRO. So it is the arm to retina time is very important. So it is the time taken for the dye from the antecubital vein to reach the retinal circulation. And it is calculated from the moment the injection is given till its first appearance in the central retinal artery. So normal is 8 to 12 seconds. So in this, the delayed arm to retina indicates then central retinal artery occlusion. So in this case, we have to be very rapidly take the photographs so as to document the central retinal artery occlusion. So on the OCT, what we can see? So on the OCT in the acute phases, we can see like here, we can see the inner retinal hyperreflectivity. So the hyporeflective outer layers and the prominent middle limiting membrane. So the late is on the late stages, that is late CRO, when the patient comes, what can we see? The inner retinal atrophy. And then it is more hyperreflectivity, there is more ischemia on FFA and more perfusion. So the more visual prognosis, that is more poor prognosis. So the ERG, that is more severe attenuation of the B wave than the A wave, and this causes the negative wave form. So it is mainly done to differentiate from the ophthalmic artery occlusion, where we have the diminution of both A and B wave. So in the systemic assessment, history is very important. History taking should be done very rapidly. and will because if the patient if the patient comes early, so it's our responsibility to save so that we can save some vision. So check the pulse to detect the arrhythmia, atrial fibrillation. Absent pulse indicates the tachycardia, and unequal on both sides is indicative of aortic dissection. Check the carotid pulses for carotid stenosis. Palpate temporal artery for GCE. So blood pressure, hypertension is a risk factor. Check Paler for anemia, cardiac consultation for any murmur, ECG to detect any arrhythmia or other cardiac disease. ESR, CRP to detect the possible GCA, and other blood tests include the fasting blood sugar level, platelets can be raised in the GCA, and the carotid duplex scanning to screen if significant stenosis is present. They can be done later. So ECG, chest X-ray, 24-hour ECG, and additional blood tests that the serum homocysteine. So these can be tailored according to the patient and at the time when the patient appears to you. Because if a patient has come to you within the 4 to 6 hours, so we try to save the eye first, because we have a critical time window, that is the retinal tolerance to ischemia, that is 97 minutes. So by this time, no permanent retinal damage if circulation is restored. It is window for the potential intervention. So after that 97 to 240 minutes, progressive irreversible damage. So we have 90 minutes with us. That is a 4-hour window period is critical. Treatment administered many hours or days after on the onset cannot reverse the irreversible ischemic damage. So regardless of the apparent circulation restoration, this explains why many claim treatment are actually natural history improvements of measurement artifacts. So these we want to save the eye when the patient comes in this during this duration. So what can we do? So any patient who has come in the emergency, that is the middle-aged female or the male that is with the history of sudden painless loss of vision, and take a quick history regarding the duration, major illness, allergies, check vision, pupillary reaction, and check the undilated retina. And within a 5 minutes, we have to take the history. Then we immediately what we can do, we can ask that is carbogen inhalation in some polythene bag. Then ocular massage can be done immediately to dislodge the emboli. Then followed by the anterior chamber paracentesis, and along with that we continue the massage and breathe in the bag. Then it is along with that immediately we can give the sublingual sorbitrate and nitroglycerin patch, and osteozolamide can be given. After 15 to 20 minutes, check the vision and see if embolus has dislodged. If not, and we can repeat the procedures for another 30 minutes. So how the ocular massage can be done? Preferably, it should be done digitally. And the aim is to collapse the arterial lumen and cause the prompt changes in arterial flow, improving the perfusion and potentially dislodging an embolus or thrombus. So positive pressure on the eye for 10 to 15 seconds, followed by followed by sudden release. And it should be continued for 3 to 5 minutes. The patient can continue self-massage if no one is available, or you are preparing for that is anterior chamber paracentesis. And during high pressure, arteries dilate by 16% by auto-regulations. On release, flow increases by 86%. So it suddenly dislodges the embolus. So there is studies have shown the use of the hyperbaric oxygen, that is a mixture of 95% of oxygen and 5% of the carbon dioxide. It is provided to induce the vasodilatation. And then but the hyperbaric oxygen increases the arterial oxygen pressure, leading to increase in nitric oxide synthesis, which leads to vasodilatation. So few studies have also shown the use of Nd:YAG laser arteriotomy also. So laser is focused deep to the arterial wall, but there are risks for the arterial wall rupture, bleeding, and nerve fiber layer damage can occur. And it is very important to give the steroids in cases of GCA. And thrombolysis, Eagle studies has shown that is on the use of the thrombolysis. but no benefit was found with the use of streptokinase or the urokinase or the TPA. So what is all the treatment, what are they doing? The sublingual isosorbide dinitrate, so the vasodilation, we are aiming for the vasodilation. Oral pentoxifylline, carbogen inhalation, then retrobulbar alpha-adrenergic blocker or local anesthetic, then hyperbaric oxygen, oculomassage, systemic anticoagulation, IV, acetazolamide and mannitol, aqueous humor removal by paracentesis, and thrombolytic and intra-arterial or systematic. So we all aim to vasodilatation so that we can dislodge the embolus and it can go into the periphery and we can revert some vision to the patient. So what can be done in the systemic management? The risk of stroke is relatively high in these cases. So urgent referral to specialist or the stroke clinic is advisable. Almost 95% will subsequently need a change in the systematic medication, and 25% will require the urgent surgical intervention. Smoking should be discontinued, and they can be put on antiplatelet therapy, oral anticoagulation, and carotid and artery by the that is the stroke specialist clinic. So the important referral is to be done. So there are many trials which have done a great work on the that is central retinal artery occlusion, but none of them found that is effective. So that is Eagle trial, 10 cross trial, revision trial. They all tried. So Eagle trial, they tried with the intra-arterial tissue plasminogen activator. Then it's IV alteplase, hyperbaric oxygen therapy, IV thrombolytic stages. So the 10th place in central retinal artery occlusion study protocol for a randomized control study. So they can that improve the outcomes of central retinal artery occlusion. But none is effective in saving the vision of the patient. The time is the key to save the vision of the patient. So in the follow-up, central retinal artery, that is patient should be followed for up to 3 to 4 weeks to look for iris neovascularization and review once the blood test reports are ready, and referral to the cardiologist is very important. So no proven therapy improves the vision in central retinal artery occlusion. Intraarterial thrombolysis discouraged. So IV thrombolysis promising only within strict early period, and it is in stroke emergency, urgent referral should be done. So now coming to the central retinal vein occlusion. So it is the second most common vascular occlusion, second after the diabetic retinopathy. In the retinal vein occlusions, we have CRVO, which constitutes that is 20%, and the 80% of the cases in ROPD are of the branch retinal vein occlusion. And out of 20% of the cases, we have that is ischemic CRVO 20% and non-ischemic around 80%. And in the major that is BRVO, we have major BRVO and minor BRVO. So hemiretinal vein occlusion, it can also occur in few cases. So Dr. Hare found that central retinal vein has two trunks in the artery anterior part of the optic nerve. So Idamine described the development of the central retinal vein and reported that from the 3rd month of intrauterine life, there are always two trunk of the central retinal vein in the optic nerve, one on either side of the central retinal artery, and one of the central retinal vein venous trunks usually disappears before the birth. So Chopdar later on reported that 20.5% of the eyes in general population showed the dual trunk, that is central retinal vein, as the congenital anomaly. So usually they say that they bifurcate here. Normally, in most of the cases, they bifurcate here at the near the lamina cribrosa or posterior to the lamina cribrosa. And in 20% of the anomalies, they can originate that is behind, also posterior to it. So what are the risk factors? The history of the CRVO in the same or the fellow eye. Then it is a primary open angle glaucoma, which constitute 5 times the risk for the CRVO. Hypermetropia because of the congested disc, retrobulbar external compression, thyroid orbitopathy, and the orbital masses. Now, that is a common systemic risk factors. Age, which is the risk factor more than 50 years of the age. Diabetes, 10 to 25% of the cases. Hypertension, 64% of the cases. Obesity, cardiovascular diseases, hyperlipidemia, and smoking. And recently, there is a term known as the vaping, which has resulting in the occlusion of that is the hemiretinal vein occlusions. Then it is the inflammatory diseases and OCPs, which results in the coagulopathies. So what is the mechanism for central retinal vein occlusion? So occlusion of the vein by the external compression by the sclerotic adjacent structure, that is the central retinal vein, which is the culprit in causing the central retinal vein occlusion, and the fibrous tissue envelope. And because they share the common adventitial sheath, so when that is artery is atherosclerosed, so it causes the compression on the vein, which results in the that is occlusion of the central retinal vein occlusion. Occlusion by the primary venous disease, that is the degenerative and inflammatory nature, and subendothelial atheromatous lesion in the central retinal artery, arteriolar spasm, sudden reduction of BP, blood discresis causes hemodynamic disturbance. So we can see here that is the thrombotic retinal blood vessels. It is pressing on the retinal vein. And here, because of the sudden pressure change, there is endothelial injury, and these patients have hypercoagulopathy factors and abnormal blood flow, which further injures the endothelial, causes the endothelial injuries. So the drainage of the central retinal vein. So whenever there is that is a central retinal vein, it is blocked. So what will happen? So what will happen, that is because of the back pressure, the blood flow, these central retinal vein is occluded. So why we find the flame-shaped hemorrhages or the dot blot hemorrhages in such cases? Because when there are the capillaries in the superficial capillary plexus, they ruptures. So we usually find the flame-shaped hemorrhages. But when we find because of the back pressure, the capillaries in the inner plexus, middle plexus, or the deeper plexus, they ruptures, we find that is dot and blot hemorrhages can be seen in these cases. So what is the pathogenesis of macular edema? Because of the CRVO, and there is inflammation, there is hypoxia, and because of all these factors, VEGF release, and because of the vasculoendothelial growth factors, and there is a breakdown of blood retinal barrier, which is shown here, and there is resultant, that is appearance of the macular edema. And because of the VEGF, it can result in the neovascularization formation, which can later on play a role in the worsening with the help of appearance of the neovascular glaucoma. So this is the pathogenesis of macular edema, that is that there is a breakdown of blood retinal barrier. So there are two types of blood retinal barrier. That is the outer blood retinal barrier. The PG students should know this. The outer blood retinal barrier, that is at the level of the retinal pigment epithelium, and inner blood retinal barrier is at the level of the capillaries formed by the endothelial cells. So what is the classification now? So why it is important to differentiate between the two? That is the ischemic type of CRVO or the non-ischemic type of CRVO, because they have different prognoses, they have different complications, and there is different management, and the outcome, a visual outcome, is also different. Non-ischemic cases, which is seen in 80% of the cases, and it is also known as the venous stasis retinopathy. So in this, it is benign, also known as benign, and the major complication is cystoid macular edema, which is responsible for central scotoma. But in hemorrhagic CRVO, that is ischemic CRVO, there is a major complication is ischemia, and because of ischemia, the VEGF is released, which is responsible for the neovascularization, and later on, which can be complicated by the 35% cases into the neovascular glaucoma and causes the blindness. So the diagnosis is important. So in the clinical test, Dr. Hare has done a great work on this. That is the functional test and the morphological test. So what they found, that the functional tests are more important in diagnosis or in differentiating between the ischemic and non-ischemic CRVO. So the peripheral visual field and RAPD and ERG and visual acuity, they come under the functional test. And in morphological test, ophthalmoscopy and fundus fluorescein angiography. So we will try to cover one by one. So visual acuity loss, that is when the vision is good. So normally it is that is the non-ischemic type of retinopathy. That is this is the work of the Dr. Harris only. So they found that the visual acuity of better than 6/60 was seen in 58% of the non-ischemic CRVO as compared to the only 1.7 in type of the ischemic CRVO. So that is the worsen. That is 81% of the cases. That is they have the better visual acuity in the cases of the that is non-ischemic type of CRVO. So so the peripheral visual field. So we can see here that is in the non-ischemic there is a central scotoma because of the CME, but in the ischemic CRVO they have the peripheral defects also in the type of ischemic CRVO. So according to the Hori said that the patients who the peripheral vision is very important. So it is important to differentiate between the two. So RAPD assessment, that is a relative afferent pupillary defect assessment with the neutral density filter. So grading in the 97 that is non-ischemic CRVO, it is usually that is 0.6, less than 0.6 in 97% of the cases, and in the ischemic CRVO it is better. In the ischemic type of retinopathy, it is worsen. It means it is more than the 0.9. So how it is tested? That is, it quantifies the severity of the optic nerve dysfunction by using the filters of varying darkness, that is the log units placed over the better eye. So the filter is placed over the better eye, and then the that is flashlight is tested, and the pupillary reaction is noted till it matches the eye undercover. So normally it is worsen. If it is ischemic, it will be worsen like that 0.9 or 1.2. If it is non-ischemic type of CRVO, it will be less than 0.6. So ERG assessment, that is in the B wave, it is less than equal to 60%. 60%. So it is also differentiating, and it is specificity and sensitivity is 80%. So according to Horace, that is he tests that ophthalmoscopy, it is the least reliable and most misleading test for the differentiation. So in the first picture we can see that it is difficult to differentiate between the two, it is ischemic or non-ischemic. So what can be the presentation? That is in CRVO, patient can present with the vitreous hemorrhage, and when we do the B scan, we can that is also have the tractional retinal detachment also, and intraoperatively we can find that it was a case of that is CRVO. And the clues for inflammatory type of vasculitis, that is there can be vasculitis. We can see here multiple occlusions away from AV crossing. So examination of other eye to differentiate with the that is inflammatory vasculitis. So role of fundus fluorescein angiography, that is it is done to see the site of occlusion and area of capillary dropouts, and it is also helps to differentiate between the collateral and neovascularization. And for the CME, we can in the CME cystoid macular edema, we can see here in the form of the flower petal appearance. So differentiation between the blocked fluorescence and capillary non-perfusion areas. So normally we
Dr. Rajvinder?
Dr. Rajvinder, are you there?
Dr. Rajvinder, would you like to unshare and then share again? I think your PowerPoint is stuck. It's not moving forward. Yeah, doctor. Yeah. Yeah, your screen is visible, Dr. Rajvinder. Please carry on.
Rajvinder, you are muted, I think.
Yeah, I think you're muted. Yeah, Dr. Rajvinder. You want to yeah, I think you should share your presentation again. Yeah, please.
So now I'm unmute.
Yes, you're audible, loud and clear.
Okay.
You just make it full screen, please. Yeah.
Just make it in a slideshow mode, please.
Yes.
Yes.
I think something is coming in between.
I think we can hear you as well as see your
It's
slides
okay,
now.
doctor. You can just click on the screen and start rolling the slides.
Okay.
Your slides are visible completely. Please continue.
बाद में बेटा. So role of fundus fluorescein angiography. So it is very important that in non-ischemic CRVO, that is the capillary bed fills very well. So there are few scattered retinal hemorrhages and engorged retinal veins. So late staining along with the large retinal vein is characteristic finding in moderate and severe degrees of CRVO. Of course. Something is coming in between. So how to differentiate between the collaterals and that is the neovascularization of the disc. When we see the caliber of the blood vessels, that is normally the collaterals are a big convoluted appearance at the disc level and they do not leak at the fundus fluorescein angiography. But as a neovascularization, in the neovascularization, they are a fine light and they usually leak at the disc. So when we sum up the test, that is we see that the functional test, that is the RAPD and ERG, when they are combined together, they have 97% of sensitivity and specificity. And that is visual field is better as compared to the visual field. And ophthalmoscopy is least reliable in differentiating between the ischemic and non-ischemic. So the complications, that is in ischemic type of CRVO, we usually have neovascular glaucoma in 33% of the cases. So whenever the age is 45 to 64 years, so the incidence is 8% and 8%, and at 18 months the incidence can be raised to 18%. So the causes for the vision loss are the macular hemorrhage, macular edema, macular ischemia, and the vitreous hemorrhage. So whenever that is the after 3 months, we will be able to differentiate that when the macular hemorrhage disappears, the vision usually improves. And on OCT can help in differentiating the macular edema. And on fundus fluorescein angiography, when they have macular ischemia, and it is usually appreciated in the mid phase, and after this it will be obscured due to the leakage, so it is usually a poor prognostic sign. Ancillary test, that is the OCT these days plays a great role, and there are OCT markers which correlates with the visual acuity, intraretinal fluid, subretinal fluid, hyperreflective dots, and photoreceptor integrity, which can help us to guide what will be the prognostic factors in these cases and how should we go. We should go directly to the anti-VEGF, or we should go with the that is intravitreal steroids. So in the natural history also, so natural history, if they are untreated, sometimes they have that in the ischemic, the vision can be as good as 20/20 in 42% of the cases. And in ischemic, they have only in 3% of the cases. And if they are not treated, the vision is usually counting finger and worse in the ischemic type of retinopathy. And how we see that it is an old CRVO. So the hemorrhages takes approximately 6 months to 1 year to resolve. There is perivenous sheathing, cilioretinal laterals, then is the macular retinal pigment epithelial degeneration, and you can find the epiretinal membrane. So what are the treatment? Medical treatment, surgical, invasive, and the photocoagulation. This is coming. So find out the cause for the vision loss, and if it is a macular edema, treat accordingly with the help of intravitreal steroids and anti-VEGF. So there are many CRVO trials. I will only name them. That is a central vein occlusion study, SCORE study in the 2019, and bevacizumab study, where they injected the monthly injections of bevacizumab, and they were found to be safe and effective. Geneva, Cruise study, Copernicus, Galileo study, discussed various anti-VEGF, that is ranibizumab, Cruise. Uh, they tested the ranibizumab, Copernicus and Galileo score. They studied the aflibercept and Lucentia, Elia, and Avastin. They are discovered in the LEVO study. So the BRVO, when it comes to the BRVO, it covers, it is common in the superior temporal quadrant, where it is seen in 66% of the cases. Why we see BRVO in superior temporal quadrant? Because there we have more AV crossing. So I will that is, the color diagram should be made in each and every case by the post-resident cases, because they usually are given these cases as a short cases or the long cases. So there are various trials in the branch retinal vein occlusion also: BIVOS, Bravo, Geneva, Vibrant, Bellatin, Faricimab, and Comrade B. So they have discussed so the later the options are the laser photocoagulation, steroids, and anti-VEGF. So in the cases of the ischemic CRVO, that is a scatter PRP should be done. And in the BRVO, that is the sector PRP should be done. And after 6 months, you can do the repeat angiogram to see for persistent NVE or NVD, because they plays a role in that is detecting the capillary non-perfusion persistent areas, because it will help in reducing the new vascular glaucoma. So it is the late complication in ischemic type of diabetic retinopathy, and it can be controlled, that is in pre-glaucoma stage with the PRP anti-VEGF, and in the open angle glaucoma stage with the that is the glaucoma filtration surgery, or and in the post glaucoma, that is the glaucoma valve and glaucoma filtration surgery, PRP and anti-VEGF. So there is a role of tight PRP to prevent the neovascular glaucoma. So role of steroids, that is second line treatment after the anti-VEGF. In patients with recent major cardiac event, we can give the steroids. Patients unwilling for monthly injections, and repeat after 3 to 4 months, and monitor the intraocular pressures. So surgeries, they are not recommended. And but a few literature is there on the sheathotomy, that is sectioning the adventitious sheath, and it is usually indicated, surgeries are usually indicated in non-resolving vitreous hemorrhage, TRD, and that is epiretinal membrane. So CRVO and CRO, they can coexist, and in these cases there is no thrombosis, no embolism. But we find that is CRVO, they coexist, as CRVO usually develops due to occlusion of the central retinal vein at the lamina cribrosa, or the posterior to the lamina cribrosa. They completely blocks the retinal circulation and converts the circulation into closed loops. So blood cannot go out as well as cannot go in. So there is complete absence of retinal circulation, resulting in central artery occlusion blockage also. So in the summary, that is central retinal vein it is the most common cause of the after the diabetic retinopathy. Hypertension is the most common, and the cause for the vision loss is macular edema. First line treatment is the anti-VEGF, and then it is a scatter PRP in neovascularization cases. Second line is the steroids, and vitrectomy for the complications like the vitreous hemorrhage, TRD, and epiretinal membrane. So the CRO, it is an absolute emergency. Treatment should be instituted within 90 minutes. Irreversible damage and loss of vision after that is more than 90 minutes. So cherry red spot is diagnostic. Treatment should be attempted within as early as possible. Atherosclerosis and embolism are the most common causes. In young patients, look for hyperhomocystinemia. Thank you, and acknowledgements to my mentors. Thank you so much.
Thank you, Dr. Rajvinder. I must say that was such a wonderful masterclass on vascular occlusions. You covered everything from A to Z, didn't leave anything out. I think there was a virtual treasure trove of knowledge for our PGs in this talk, and my compliments to you. So I think a lot of points have already been discussed in these talks. I'll quickly go over to the discussants for any short pointers or any perspectives they would have before we move on to our next talk. Thank you, Dr. Rajvinder.
Screen बीच में
That's all right. These things always happen. We have no control over them.
It was
But
such a
wonderful.
difficult task actually
Wonderful. Yeah.
to have to cover the artery, vein, branch, and central. Very difficult job. I think you did a great job, Dr. Rajwinder. I just wanted to add a couple of points. The vitreous hemorrhage, especially in branch vein occlusion, is not always because of neovascularization. It can be a breakthrough hemorrhage, and we need to be more meticulous in looking for the reason for vitreous hemorrhages in vein occlusion, not taking it for granted, thinking that it is always a secondary to new vessel proliferation. And the second point which I wanted to add was especially when there is a recurrence of edema or non-regressing macular edema secondary to vein occlusions, always look for new hemorrhages, or it does not mean that once there is a vein occlusion, it cannot happen again to the same eye. If the BP is not, if, especially when there is a systemic fluctuation which is happening, it's not under control, there can be a overlapping of new vein occlusion which can happen over a old vein occlusion that can be a reason for a non-regressing edema. I mean, non-resolving edema. So that needs to be kept in mind, and an angiogram can help in those cases. So yeah.
Thank you so much. Excellent pointers. Any of the other panelists, Dr. Dhanshri, Dr. Vijay? Dhanshri, ma'am?
Yes, yes. Excellent talk, Dr. Rajvinder. She has covered most of the, I mean, almost all of the thing. I just wanted to add a few that, see, central retinal artery occlusion is a true emergency, and each and every ophthalmologist must know how to handle it. So there is a, if the patient comes, you must know. So all the postgraduates, they must know how to manage a case of central retinal artery occlusion. Second thing is that there is always a risk of developing CRAO in the other eye. Like you have a great risk of stroke, but you also have a risk of developing some other occlusions, such as even the other eye can get involved. There is about 20% risk. So you must inform the patient about first aid. Uh, Measures, like I always tell the patient that if you ever get any vision loss in the other eye, you must always do this, immediate carbogen inhalation, start massaging your eye. Also, I'd ask them to carry a nitroglycerin patch so that they can just put it on the skin anywhere, and start the dilatation, and to rush to the ophthalmology, any eye doctor immediately. Second thing is that very often, despite multiple investigations, you might not find any cause for either the CRAO or the CRVO. But it is important to investigate the patients because of this secondary risk of stroke, or there is increased mortality also. So you must check on that. And there are often times sometimes the patient may, you might find some heart disease in such patients. And the fourth thing is, it is rare to have central retinal artery occlusion in young patients, but you do come across a few cases. And one of the publications which Dr. Rajvinder mentioned was another study done by us, and it showed that in the young patients, the most common cause was hypercoagulable state because of hyperhomocystinemia, and because of uh, it is linked to vitamin B, metabolism. And because malnutrition is so common in India, so there is a chance that patient may have hyperhomocystinemia, and they may end up with vascular occlusion. So always check for homocysteine levels, and you can treat them very easily with vitamin B and folic acid supplements. Thank you.
Thank you. Dr. Oboli, any comments before we move on? You're running a little late.
Yeah, no, she has already covered extensively. Nothing to add from my end.
All right. So if we'll just move on quickly to the last talk of this episode, and that will be by Dr. Dhananjay Shukla, who's a vitreoretina, very senior vitreoretina consultant from the Ratan Jyoti Netralaya at Gwalior, and he will be speaking to us on hypertensive retinopathy, another very important and very pertinent and relevant talk for our PGs.
Thank you.
Welcome, Dr. Dhananjay.
Thank you, Dr. Tenku. Am I audible?
Yes, you're audible, yes.
Let me see if I can share my slides. And I, first of all, thank Dr. Dhanishri for telling me how to open my camera in the first place. Is my screen visible?
You are visible, your screen is not. You'll have to share the screen from that little green icon there which says share.
Just a minute. I
So if you look at the
yeah,
bottom of your screen, there's a
yeah.
share. It says share.
Yeah.
And you could keep your presentation on your desktop and yeah.
So is it visible? Should I put it on full screen?
Yes, please do. Yeah.
Thank you. So I thank Dr. Tinku.
It's not on full screen. Yeah, perfect. Perfect. Please carry on.
So I thank Dr. Santosh, Dr. Tinku, and all the Gurugram team for inviting me for this talk. So now we must start with why always, whenever we want to know about something. There's a beautiful book by Simon Sinek. Why should I bother about hypertensive retinopathy? So first thing, will it be useful to pass my exams? For PGs, no, probably not. Actually, most examiners don't bother about it. Is it embarrassing not to know about it? Probably, but still most people don't do, so it doesn't matter. Will it help me handle my bread and butter surgeries better? Yes, if you're talking about hypertension, but no if you're talking about hypertensive retinopathy. Will it bring me more money, which applies to most of us? It will not, because we are not treating hypertensive retinopathy. But if the question is, will it help more and more patients or most patients in the world? The answer is, resounding yes. So I'm also covering what I'm not covering this talk, that is BRBO, CRBO, beautifully covered already, where hypertension is the risk factor. My favorite topic, NAI1, I cannot cover here. MACTEL, retinal macronisms. So these I have to leave behind. So let me begin the story. This gentleman you see here, I'm sorry, Mr. Franklin Roosevelt. He was the longest serving US president, but he could have served longer actually. His blood pressure in his 60s used to range above 180 by 100. And believe it, when I say that, it was considered normal by the US White House physicians as normal for his age. And he went untreated for nearly a decade when a fatal stroke with the BP skyrocketing to 310 by 190. Now, even the diastolic ranges, what is in systolic called malignant hypertension. And he actually ultimately succumbed to it with a massive stroke. Unfortunately, we haven't learned a lesson still. So this is the background for my talk. This is based on a review I recently wrote for Indian Ophthalmology. So let's begin with what is normal hypertension. What is hypertension, by the way? So first of all, we have to brush ourselves again, because the recent guidelines say a blood pressure of 120 by 80 is not normal. It's elevated. So if you have blood pressure of 120 by 80, you have to brace up and change your lifestyle already. If it is 120 to 129 or 80 to 89, you are already stage 1 hypertension. And if you're already above 65, have diabetes, kidney disease, or cardiac disease, you have to start pharmacotherapy. However, in any condition, if the BP is 140 or 90, not above it, if it is only 140 by 90, it is the WHO definition of hypertension, and it always requires therapeutic treatment. So the most important thing we have to remember is it's a global burden. It's a commonest systemic non-communicable disease and affects 1/6 of the world's population. So that's why I say hypertension is important for us. And about 1 crore of people die every year from hypertension. And again, it's a tip of the iceberg, because it is underreported in about half of the US citizens and even 70% of the Asians. 1/5 of the world, which is already diagnosed, is undertreated, and only 1/10 of the Indians who are actually diagnosed are controlled. So there's a very tragic truth. Not only that, it is not suspected in the young. So about 20% it is of our patients in 20 to 44 years have hypertension, more than 10% in 18 to 19 years, and even children less than 18 years, they are hypertensive in about 7% of cases. This problem is further worsened by faulty measurement by the paramedics. So to start with pathophysiology, which vessels are affected or which tissues are affected, how and why. So it's primarily a disease of retinal arterioles, which everything that you are seeing in the fundus is basically retinal arterioles, but especially precapillary arterioles, because they are more vulnerable because of thinner muscular coat and thinner elastic lamina. The other important thing which you forget is choriocapillaris and RPE. So there is an initial slow phase where there is a vasoconstriction and vasospasm followed by vasosclerosis. So here the retinal autoregulation comes into picture and causes narrowing and hardening of arterioles. But after this, or sometimes without this, there is an acute BP spike which can happen in young or in old, and which is a completely different ballgame. It's a fibrinoid necrosis of the arterioles or the choriocapillaris and RPE, and it causes vasoocclusion. Infarcts, if at the level of retina, they're called cotton wool spots. If at the level of choroid, they are called Leschnick spots or secret speaks. There can be bleeds more commonly in the retina and leakage more commonly in the choroid. I'll come to it later. So first, let us learn about the staging of hypertensive retinopathy, first given by Keith, Wegener, and Barker. They graded into 4 grades. The initial 2 grades were of narrowing, hardening, and focal narrowing of the arteries. So then what does the narrowing do basically? You can, it's difficult to recognize the generalized narrowing or even the focal narrowing, but you can easily see AV nicking. So this is what we must be able to detect actually. And I'll show you it is not so easy and you have to look for it to detect it. Grade 3 is where the proper retinopathy starts with flame hemorrhages, cotton wool spots, and macular star. And grade 4 the stage where disc edema happens. But they did not tell us anything about the choroidal vessels. So for example, if I give you a small quiz, on the this picture shows Keith Wegener stage 1 and this shows a stage 2. If I don't put the arrows, it's difficult to see that there are copper wiring of the arterioles in this, and there is a distinct AV crossing change which you can see here. Michel and Wong modified or rather simplified this classification more recently in NEJM 2004. They basically clubbed the stages 1 and 2. That they said that generalized or focal narrowing doesn't make a difference, but this kept the stages 3 and 4 as before. So it was not much of an improvement. So what I found lacking with these classifications, first of all, these are not classifications of hypertensive retinopathy. They are actually grading of the severity of hypertension. So they should not be classification. The second important thing is they clubbed acute and chronic changes, which is a very important thing actually. So if you look at hypertension, it first causes a slow change causing the hardening of the retinal arterioles, mainly tunica media, which results in avoidant reflex, silver and copper wiring, and AV necking. But it's actually the things blow out when there is a stage of retinopathy, when there are flame hemorrhages, cotton wool spots, macular star, with or without a disc edema. So this is what signals the end game. We have to check the BP, and if there is a high BP, as we just saw, I'll discuss again, we should refer the patient for physician and should not wait for the disc edema. And more importantly, we have to remember that grade 3 or 4 hypertensive retinopathy does not always follow grade 1 or 2. And therefore, grading is probably not as valid as it used to be. So who told us most about this actually? Dr. Sohan Singh Here, in 6 seminal articles and archives, he said that the acute hypertension is not a retinopathy, it's primarily a choroidopathy. But the changes are subtle. They are hidden by the more prominent hypertensive retinopathy changes, and the serous detachment, which is almost always there, is not seen. For example, in this picture, you cannot see the serous detachment. You cannot see the disc edema. You can see the cotton wool spot, but you will be easily missing out these lesions, which I'll tell you a little later about. So it involves the disc frequently, which is also supplied by choroid, and not surprisingly, NAION is the commonest cause of unilateral disc edema in middle age. But despite this, we call disc edema as different actually. So to talk about disc edema is to talk about malignant hypertension. It is the emperor of hypertensive maladies. Why? Because if you do not treat a patient with malignant hypertension, he will die within 1 to 2 years if not treated actually. The most common cause of death in these cases is renal disease, but the prognosis has improved over last 4 decades, but the incidence remains the same, which is alarming because of all that's underdiagnosis. So how do we define malignant hypertension? It's severe hypertension with papilledema. And what is severe hypertension? Severe hypertension is a systolic blood pressure of 180 or above, and or a diastolic pressure of 110 or above. And both of these are on their own a sufficient criteria to diagnose malignant hypertension. A reconceptualization of this definition has recently happened, which now strengthens more on target organ damage. Basically, we are talking about kidney, heart, and brain. So, but more important thing, we have to remember that we don't have to wait for grade 4 hypertension or disc edema. Grade 3 hypertension is now recognized to be enough to label hypertensive retinopathy as malignant if there is severe hypertension is associated. Because disc edema sometimes may not be even bilateral. So what do you call it? Grade 3/4 or grade 3.5 or grade 4. So we found that there's a more important criterion called macular detachment, which here already told about. We studied this and published our findings 2010, and we found that serous detachment of macula was more common and more authentic criteria to diagnose a malignant hypertension than papilledema. In fact, in the cases where you see a macular star, very frequently it is actually a follow-up. Many of these cases actually have already a serous detachment. It is generally following a resolution of serous detachment rather than a macular edema. But what about choroid? Remember, I'm sorry, the target organ damage that we call the eyes, kidneys, heart, and brain. The kidney is most important because the choroidal and kidney circulations run in parallel. They are similar lobular fashion circulations. And what happens in kidney also happens in the choroid, actually. So while the retinal changes are transient, that is, they disappear completely without a trace, the choroidal footprints remain. So what you see as Elsnick spots acutely as pinpoint dot spots, sometimes they, in fact, are bigger and look like choroiditis. And I'll show in some case reports later on. And the other picture, which is described in late phases, is a secret streaks. So they are streaks of hypo and hyperpigmentation seen in the mid-peripheral region. So these can be seen better by autofluorescence, but even clinically, if you are careful, you can see them. And they are clear-cut footprints of a malignant hypertension after it has happened. So the patient may come to you with a normal BP, but if he has this picture, you have to suspect that the patient has had a history of acute BP spike and take due care. So I'll illustrate with some case reports. So this patient was referred to me by one of my fellows from South India by email. Now, look at the age. He was 30-year-old. He presented with a dark scotoma in the right eye for 5 days. He had fever for 1 week, 5 to 6 days before the onset of the ocular symptoms. So one was thinking of post-fever retinitis. But the vision was 6/6 in both eyes, and other things are also normal. So when he looked at the fundus, he could only see some cottonwool spots. Now, there are some lesions here, here, and here, which are subtle, but he obviously missed them. When he did the OCT, he found a serous detachment in both the eyes, but it involved the macula more in the right than in the left. However, the vision was 6/6 in both eyes. He did a full investigation. He did inflammatory as well as the regular investigations. So blood pressure was normal. Mantos was negative. ESR was low. He did a fluorescein angiography, and to his surprise, he found much more lesions than the cottonwool spots visible clinically. I'll show you the clinical picture once again and come to the fluorescein angiogram. So you can see there is a mild leakage of the disc. The lesions are deeper. They are, it's almost like small CSR kind of leaks, which are appearing at a deep level. So in frustration, because he didn't know anything better, he started the patient on oral Visalon, which we all do. When we don't know what to do about a patient, we start on steroids. The patient came to follow up after a week, but he had more blurring of vision in the right eye, and more scotoma now appeared in the left eye also. Now, previously he was 6/6 in both eyes. Now he was 6/18 in the right eye and 6/9 in the left eye. Anti-segment was within normal. Fundus had only changed a little, actually. You can see there are more cottonwool spots. Again, look at those mysterious lesions here. And the surprise was in the OCT. The right eye, which had the vision of 6/18, the macular detachment had actually decreased. And the left eye, which kind of preserved the vision, had a big serous detachment. Now I'll hold the suspense and go into case 2. This is an even younger patient, 26-year-old, with a defective in both eyes for 5 days. Now, previous patient was 6/6. This was 6/16 in the right and 6/18 in the left, healthy. With this picture and this periphery, they thought of retinitis or multifocal choroiditis, which has been discussed just now. The workup was, negative for anything. BP was normal, and inflammatory investigations were also normal. I'll again jump to case 3. Now, this was 65-year-old female. She had a pain in both eyes with visual defect for 15 days Now she had much worse vision, 624 on the right and 4/16 on the left. The cataract was there, but not correlating with the vision. No systemic illness, BP, blood sugar normal. This was the funded picture in the left eye, in the right eye. Now you can see some features of hypertensive retinopathy, but the patient's BP was normal. So the common thread was we don't record the BP ourselves. Our paramedics record the BP, and because two of the patients were actually very young, and because of the auscultatory gap in the carotid cuff sounds, the diastolic was probably recorded as a systolic BP because they never pumped the blood pressure instrument enough to take it to 200 or 190, which was so all the three patients had malignant hypertension. So when you see a picture which is conducive to correlates with hypertension, but the BP looks normal, just repeat the BP yourself. So what about the detachment, decreasing and the vision still worsening? It was related to ischemic optic neuropathy, which is always known to accompany hypertensive, malignant hypertension with disc edema. So disc edema is not just disc edema, it is ischemic optic neuropathy as well. The mysterious patches was actually all ischemic infarcts, which look like choroiditis sometimes, and this is how they appear on fluorescein angiography. We don't have to do fluorescein angiography anymore because you can see them on autofluorescence much better. Now I'll talk about a very common association. When patients are diabetic, they are almost always hypertensive as well. So how do we grade diabetic retinopathy in a patient who also has hypertension, which is almost always? So most people don't do actually. They just grade diabetic retinopathy. They don't bother about hypertensive retinopathy, and it's a mistake, and I'll tell you why. So these patients, first of all, sometimes they don't require treatment, and I'll come to that later. But you first, how to detect them? They have more of flame hemorrhage than dot and blot hemorrhage, as you see in this picture. They have more cotton wool spots because the nerve fiber layer is more involved. They have a macular star, which is not seen in diabetic retinopathy. Now, more importantly, the nasal macula is more thickened, and the background changes are centered around the optic nerve head, actually. So on OCT, if you have OCT, you can find that they almost always have serious detachment. And some cases, if they have a chronic hypertension, you can also see AV crossing changes. But if they are young patients, as two of my patients, you may not see any. So this background, I'll come to case number 4. He was referred to me as a case of papilledema with severe NPDR. Now, he's a 42-year-old male with diabetes only for 6 years, and vision was 1/60 in both eyes. So he was practically blind. His CT scans were already done outside. They were normal. Now look at the picture carefully and see the centering of the lesions around the disc.
Dr. Dhananjay, are you there?
I think he has a poor connectivity, ma'am. It's frozen.
Yeah. It happened in the previous talk. It's happened in this
Yeah,
one.
yeah.
Dr. Dhananjay, would you like to log out and then share your presentation again? I don't think he's... Dr. Dhananjay, can you hear me? No. So I think we'll just go in with a few comments from the discussants in the meantime. Dr. Dhananjay is trying to log in again, I suppose.
So I will go first. I mean,
Yeah,
I
please,
had the
please.
privilege of listening to Dr. Dhananjay's thought process about hypertensive retinopathy in 2022 when he came for a talk in Arvind. So I personally speaking, this thought process of steroid first therapy for hypertensive retinopathy is something which I have implemented in my practice, and I have seen much better results. And the arguments he puts forth about the inflammatory pathology and the eye needing steroids is something which over time, with my experience, I tend to agree.
Thank you so much. Any of the other panelists, would you have anything to add or any comments to make? I particularly liked Dr. Dhananjay's case series of the patients whose blood pressure was erroneously measured. And that is a very common scenario in practice. You would clinically think the patient has hypertensive changes, but then he comes back with a normal reading. So if I have a BP instrument in my clinic, I make sure that my attendant checks the BP right in front of me. Uh,
That was one
anything
good
else?
point which Dr. Dhananjay made, that you must check the blood pressure again,
Yes.
because often you cannot rely on that. And if you strongly suspect hypertensive retinopathy, then definitely you must check the BP even twice, thrice also. And very often, once you control the blood pressure, these changes will reverse, especially in younger individuals. So I think the first treatment would be to control the blood pressure and then wait and watch. So there's no need to go in with anti-VEGF injections immediately because of the serious macular detachment. So very often all these changes will subside once the blood pressure normalizes. So just concentrate on treating the blood pressure and keep reviewing the patient.
True.
Just wanted to add on to the uh, already mentioned points is preeclampsia patients, pregnancy-induced acute hypertensions, which when they come with the classic appearance of NSD, neurosensory detachment, where they are labeled as CSER. So whenever such like especially women with pregnancy who come with both eye NSD or neurosensory detachment, it's very important to go and get their it's like acute raise in, they would have gone into preeclampsia. So many times we will be sending them to gynecologists to get into the treatment. So I think pregnancy, eclampsia, hypertensive retinopathy is something which we always have to keep in mind in women. Yeah.
Yeah, I'm sorry, I lost my Wi-Fi actually.
Yeah, okay. Good, you're back.
And
Would you-
where was I actually? Had I discussed was this case seen? I'll start here.
Dr. Dhananjay, I think you'll have to share your presentation.
Yeah, okay.
We can't see your presentation on the screen.
Give me a second.
Yes, you were right here.
Yeah, so fingers crossed for any more glitches. So this patient did not improve at all in the first week, but over a year he improved considerably in both eyes, more in the left than in the right. And this case was really dramatic because this was a 15-year-old boy and he was referred as a case of new retinitis. He had a vision of 660 in the right eye and 680 in the left. And again, this was found to be a case of pheochromocytoma. But just by checking the BP, we knew what to do. And after just 5 days of systemic treatment, he improved in both eyes, actually dramatically. So a malignant hypertension with poor vision, the cause for poor vision is when the papillomacular bundle takes a hit, or because the ischemic optic neuropathy happens. So NAION in severe hypertension is not same as NAION in regular hypertension. So to summarize, why should we bother about hypertensive retinopathy? Most importantly, because every third adult on the planet is affected. Most of them don't know about it. Those who know about it are not treated fully, most of them, and it affects eyes. And that's a good enough reason to my mind. And this is one rare case we can sometimes even save morbidity and even death, as you have seen in some of my patients who I just diagnosed as malignant hypertension by looking at the fundus. Because most of these cases deny the history of hypertension itself, let alone malignant hypertension. And we can avoid unnecessary tests like serology for inflammatory disease or MRI for disc edema. We can improve the visual outcome by treating hypertension for better results in DME. We should prescribe steroids and DME when the patient has associated hypertension because they respond better to steroids. And we should also know when not to treat DME at all or just treat the blood pressure as you saw in the one of the cases. And what should we do next about it? We should probably lower the age limit for checking BP in our OPD patients from 40 years to 30 years, because after 30, every third in the planet again begins to have hypertension. We should recheck BP if hypertensive retinopathy like changes are present in the fundus despite young age or a negative history. We should check BP before dilating pupils and starting steroids. And more importantly, we should learn about the target organ damage and hypertensive retinopathy and choroidopathy. We should respect acute retinopathy even if it is grade 3 and disc edema has not yet set in. And we should learn to read the choroidal signs and footprints. The times, they are changing. This line by Bob Dylan is fortunately is coming true in hypertensive retinopathy. UKPDS, a full 50 years after the tragic death of the American president, still called a BP less than 180 by 105 as conventional control and 150 by 85 or less as tight control. But a recent meta-analysis this year showed that if the BP is more than 140 by 90, it is the biggest modifiable risk factor for stroke, dementia, and age-related depression. So does the BP always rise with age, or can we do nothing about it? We all think so, and actually it is shown in the studies as well. But I was surprised when I read this landmark book by senior professor of human biology and evolution, Dr. Daniel Lieberman from Harvard. He says that BP remains stable in the African hunter-gatherers from the age of 18 to 80s. And modern society can also aspire to have similarly stable BP with active lifestyle and sensibility habits. So the answer is yes, it does change with age, but it doesn't have to, and it does not always do because of aging itself. So these are dramatic differences between the American adults and the African tribe I was talking about in the incidence of BP. And as Gandhi said, we should be the change, so it starts with us. This is a picture of Dr. Daniel Lieberman himself, who is called a barefoot professor because he has run several marathons and ultra marathons. And just as a minor pointer, my blood pressure is the same as the blood pressure of my younger son, who is only 14. Thank you very much.
Thank you so much, Dr. Dhananjay. That was an extremely interesting, a very relevant and a very practical talk. And it was interspersed with these very interesting cases where you highlighted so many, nuggets of information that would be so very useful to everyone watching this webinar. So thank you so much.
Thank you.
Compliments for the excellent presentation. So we've already had a brief discussion while you were missing in action.
Okay.
We already discussed your presentation. So I'll go over to the discussants again, and if there's anything else that they would like to comment upon, most welcome. Dr. Obuli has already spoken. Anyone else? Dr.
Excellent
Tapas?
talk.
I just told discussion that I had a privilege of listening to this couple of, I think 3 years ago at Arvind. So it changed the way I see hypertensive retinopathy and I treat hypertensive retinopathy. So yeah, I've been implementing whatever you have said in 22 ever since that, and all of my hypertensive retinopathy patients are started on Ozudex, and they have very good recovery, even of the anatomical, if not visually, but at least anatomically. And yeah, thank you, sir.
Dr. Dhananjay, I request you to, you can unshare your screen now. Yeah.
Yeah, sorry.
So we've reached the end of the webinar. We have some questions on the ROP talk. So could we just take them up very quickly? There's 2-3 questions on YouTube. So I'll just put them very quickly to the panelists. Is more than one anti-VEGF safe, or should we take the patient up for laser after the first anti-VEGF? Dr. Tapas, would you like to take that?
Yeah, thanks for the question. No, and there is no rule of thumb. Usually, the patient to patient, the decision varies. Though my goal is usually, if I have to treat the patient again following anti-VEGF, usually I do the laser. But there are exceptions to this. The exceptions include if you have no response, or a response which happens too early, and the indications for which you have given injection still persist at that time. I will simplify it. Say, for example, you have taken a very posterior zone half ROP. We have injected anti-VEGF, But you see after a week, there is no response and the disease is worsening further. And the disease continues to be in posterior zone 1, or the baby continues to be sick. So that is the case where I use a repeat anti-VEGF. Otherwise, the second anti-VEGF, the second treatment is usually laser for me.
Thank you so much.
And the second injection will be after how many weeks, or after the first injection?
So the repeat injection is depends on when you see there is no response or a reactivation. That is the
So
time.
is there any minimum period you'll want to wait?
No, I usually like there are examples you have. If you have an extremely posterior disease, sometimes the VEGF load is so high. If you like anti-VEGFs, like say if you give ranibizumab, sometimes you see that there is no response at all and the disease continue. Say today you have given injection, after 7 days you see the tortuosity and dilation continues to increase. So and the disease worsens. Those cases I would go again for injection, repeat injection.
Thank you. So the other question that we have is, Dr. Sushma, would you like to take that? It's on zone 3 persistent avascular retina, less than half clock hour, and the patient is 40 weeks. Would you laser or observe?
So that's a very good question, actually. That's exactly what I was trying to say during the discussion, that persistent avascular retina and its significance is a huge importance for topic of importance because of anti-VEGF. The definition of significant PAR is more than 2 disc diameter. So if there is a persistent avascular retina above 50 weeks, more than 2 disc diameter, I would really want to, take it up and laser that area where there is a vascular retina, because beyond that, the baby is going to become bigger and it might need an anesthesia, under anesthesia laser. So I would wait till 50 weeks, 50 to 60 weeks is what they say. And if it is more than 2 disc diameter, I would laser. And vascularization beyond that can happen, but it is very difficult to monitor. So that is a reason why this thing. And just another point to the previous discussion where repeat injection. So it's very important to know why the disease is not regression, because many times the injection has itself not gone into the eye. So you have not treated to begin with. So that's the reason why, especially the amount, and there'll be somebody else pressing the injection. So make sure while giving the injection has gone inside. So, and usually within first week of the primary injection, there should be little bit of regression of the vessels, the tortuosity and dilatation. That's one of the sign that the injection is gone inside and acting. So if within first week of the injection there is no response, or you're not seeing any difference, then I would actually doubt that did the injection go inside to begin with. So that is one of the reason why you might have to inject earlier. Otherwise, you can wait until 4 weeks and see how the disease is responding, and as Dr. Tapas said, take the decision accordingly. Yeah.
Thank you. Thank you so much. So with that, we've come to the end of this very, a very long webinar, but very knowledge-rich webinar. And I thank all the participants for their very, very pertinent contribution. I thank Dr. Reshma, Dr. Vijay Pratap Tomar, Dr. Sujata ma'am, Dr. Rajvinder, and Dr. Dhananjay Shukla for their very superlative talks. And also to the discussants, Dr. Dhanashri Ratra, Dr. Mukesh Purwal, Dr. Abuli Ramachandran, Dr. Sushma Jaina, and Dr. Tapas Padi for all their excellent comments, perspectives, and discussions. So thank you all so much. Rolika, would you like to say something? Is Rolika there? No, she's not. Okay, so
Thank you for the opportunity that GuruSangam has given us. Thank you once again.
Thank you. Thank you. I'm sure the PGs are going to go back with a great wealth of knowledge after this episode. And with that, I bid you all a very good night. Once again, thanks to all of you and also to everyone who's been watching this episode. And just to inform you, this is a regular series of episodes that are going to be there on every Saturday evening, Sunday morning, and Sunday evening. So I request everyone watching to please log in again next Saturday and Sunday. So with that, I bid you a very good night. Thank you.
Thank
Thank
you.
you.
Thank you very much.
Thank you. Good night.
Good night.
Thank you, ma'am.
Good night.
Good night.
Thank you, ma'am.